Hello and good evening, everyone. Good evening to this discussion of human anatomy. I'm Dr. Ashwani Kumar, and I'll be taking care of this part. Well, I think this session goes live on our YouTube channel as well. So this probably the first session is viewable to everyone. So before we start with the class, and in the meantime, other people will join it. Let us just kind of know about how we're going to go about these days for discussion. What Telegram group we need to follow, that one common portal will have, and just a quick, just a few introductory thing, so that the class goes on very smoothly, and we will sail through this anatomy part. So the first and the foremost, we need to have a one common point of contact, because there are many people who will be attending this class live, and then obviously some of you will be watching these classes later as well. So I thought this will be a good idea that we will have one common point where we can communicate. And therefore, there is a group here, guys. I would like you people to scan this, or you can take a snapshot for now. You can scan it later. But there's a group called as Anatomy Doubt Clearing Group 2024. We have created this group now only, and many people are already joining it, as I can see. And eventually, we will use this group for everything here. I'll be sharing all the images here. I'll be taking care of your questions, your queries, anything. So that we have one dedicated group for the anatomy group, for this specifically for this batch, for this class, right? So please make sure that you scan this and be a part of the group here. And all the groups of DBMCI which are in which this class is going live, we'll make sure this QR code is shared with you there as well. Okay, let's set some rule for the classes. The reason I'm saying rule, I mean, it's not any hard and fast rule. It's just that when we want to go through these classes smoothly. So what happens when a large number of people are attending the session, that some might be having a doubt on a particular thing. But problem is that if I'll answer that doubt ready there itself here, then obviously maybe the hundreds of people who are attending us live, that may not be the doubt for those people here. They will get disturbed for no reason. So what we're going to do is, guys, during when I'm taking up a topic, I'll make sure I'll just take the topic only, and I'll keep my phone on the flight mode. I will not be watching in my phone at all, so that I can dedicatedly teach you that topic here. Make sure keep your group doubts ready. Your doubts will not go unanswered. That is my promise to you. What will make sure that in the break time, and even after the class also, the group will be open for discussion. I'll be a part of the group here. But during when I'm taking a session, when I'm taking a topic here, I'll put the group on the flight mode. Only my team will be able to see the group, so that you can tell them if there is any technical problem is there. So they'll be aware of it. Otherwise, for the queries or the questions or anything point of view, I will only be able to see your messages on your whatever questions you will post, or whatever questions you want to ask, only in the break time or after the class, right? Also, during this class, I'll be showing you a lot of images in between. Whatever images I'll show you, whatever images I'll label for you, I will make sure that after the class, and again in the break itself, I'll just take a snapshot from my tab and I'll share those images in that group, so that you keep getting those images with you simultaneously. Giving a pre-labeled image in the beginning only, I feel it's not a good idea. Unlabeled image anyways is not a good idea. So I'll show you unlabeled images only. We'll label it in front of you, and then I'll share all those labeled images in the break time and after the class. And eventually the more we keep on going toward the topics, and you will keep getting those images. Regarding the, the sequence, the people who are having a schedule, they already know that how it is, how we have planned it. But if you're not aware of the schedule, let me tell you guys, we are starting with the topic that is head, neck and face. A big unit, a very big unit in fact. After head, neck and face, we'll go to the neuroanatomy. After neuroanatomy, we'll go to the embryology. And then we have a thorax and upper limb and lower limb and abdomen. That's how we're going to basically proceed. So basically the first two topics that you should remember, that in the coming days, we are going to cover up the head, neck and face and the neuroanatomy in good detail. I'll be discussing questions also in between. I will be telling you what are the PYQs also. So everything will be happening in between. So we'll make sure that I'll try my best to make this anatomy as palatable as I could. And I hope that I'll be able to succeed in that. Okay, so guys, without a further ado, I think we'll start with the topic, and we are going to start with the first topic. And again, I'll tell you something, the sequencing is something which is very important to me, because I need to survey the topic, because none of you, I guess, is the first year student. If you're even second year or beyond second year, any batch you belong to, intern or post intern, the sequencing of the topic becomes important because I need to serve you the topic in a way that they becomes clinically more relevant to you. If I'm going to discuss about the triangles of the neck, I need to take you toward the triangles of the neck in a particular way. I'll tell you about the cranial nerves first, the deep cervical fascia, and so on. I mean, basically, this is how we're going to proceed. This is how we're going to take our topic further. We are going to start from a particular, like let's say we are starting with the cranial nerve. So that cranial nerve should be very helpful in the next topic we're going to discuss. The deep cervical fascia. After that, we'll discuss the dura mater dural venous sinuses. Then we'll discuss the triangles of the neck here. So they will keep on assisting each other here. So there's a sequence which I have developed for my own classes, and I hope that you will also understand. And in fact, you will understand the importance of the sequence a little, like probably in an hour or so, when you'll start seeing that, okay, whatever we discuss in the first 15 minutes is now getting useful. So guys, without a further ado, how about we get started? Cranial nerve nuclei and columns. Now, why are we starting with the cranial nerve nuclei and columns? We need to discuss about the cranial nerves. Cranial nerve nuclei and column is more like a topic of a neuroanatomy, but I wanted to start head, neck and face with the cranial nerve nuclei and column only because before starting with any cranial nerve, I need to know exactly where the nerve is starting. We have all the nuclei present in the brainstem, whether it is third nucleus, fourth nucleus, 6th, 10th, 12th, whatever nucleus, we have all the cranial nerve nuclei present in the brainstem. And generally when we talk about the cranial nerves, we discuss the cranial nerve from, okay, how it came out of the brainstem, various relations, and how it is going to supply the structures. But knowing the cranial nerve nuclei first will tell you what is the sequence, how exactly it started, what is the exact point of origin of the nerve, the location of the nuclei, which part of brainstem it is present here, is it doing something inside the brainstem or not, and then coming out, and then understanding how to differentiate the different type of cranial nerve nuclei. What are the parameters on which we divide the cranial nerve nuclei? Okay, so to guys start with, in the cranial nerve nuclei and column, I need to start with some basics first. Pharyngeal arches. Yes, I agree. Pharyngeal arches is a topic of the embryology, but as I said, I need to start from somewhere. So we are starting with this, the pharyngeal arches. Okay, how many pharyngeal arches do we have? We have like first pharyngeal arch. There is a second arch, third arch, fourth arch, and we know fifth arch disappears, so we have a sixth arch, guys. We got a first, second, third, fourth, and the sixth arch. These are the 5 arches that we have. Fifth arch appears, but later on the fifth arch is gone. So we have like 1, 2, 3, 4, and 6 arch. If I broadly talk about the nerve supply, the first arch is supplied by the mandibular nerve. We are going to discuss all these nerves in detail, but just to know that first arch is supplied by mandibular nerve. Second arch is supplied by facial nerve. Third arch, glossopharyngeal nerve, whereas fourth and sixth arch, they both are supplied by the vagus nerve. Yes, different branches of vagus, but it's vagus here. Mandibular nerve, facial nerve, glossopharyngeal nerve, and vagus nerve are the nerves for the pharyngeal arches. Guys, mandibular nerve, it supplies what muscles? Mandibular nerve is known for supplying the muscles of mastication. Well, broadly they supply the muscles of mastication. They do supply other muscles also, but they supply muscles of mastication. Facial nerve, it supplies the muscles of face, or you can say muscles of facial expression. Again, mainly the muscles of facial expression. Though mandibular nerve and facial nerve, they supply beyond muscles of mastication and facial expression also. But as I said, broadly they're supplying the muscle of face and muscle of mastication. Glossopharyngeal nerve and 10th nerve. 9th nerve and 10th nerve, they collectively, if I talk about both the nerves together, they collectively supply the muscles of palate. They supply the muscles of pharynx. And they even supply the muscles of larynx. Palate, pharynx, and larynx. I encourage you all to please make your own notes. Don't rely on any written material. If you are in position to make the notes, please go with that. So mandibular nerve, guys, mandibular nerve, muscles of mastication, facial nerve, muscles of facial expression, and 9th and 10th nerve, they supply the muscles of palate, pharynx, and larynx. The question is, why are we discussing cranial nerve? Why we are discussing the pharyngeal arches when our topic is cranial nerve nuclei? Look, first we need to understand that what are the types of muscle we have. Unless you don't understand the types of muscle we got, then how we will understand that, okay, what type of nerves are required to supply them. So it's just about the game of the demand and supply. Let's understand the demand first and then we'll go to the supply part. The demand is, if I ask you a simple question, what are the types of muscle we have in total? Then we'll say, okay, we have a skeletal muscle, we have smooth muscle, we got cardiac muscle. A simple straight question, smooth muscle, cardiac muscle, and skeletal muscle. But when you think of the same question with respect to only head and neck, forget about rest of the body. Just let's keep the rest of the body on rest for now. Just think of only head and neck part. Now in head, neck and face, we can say again the muscles are of three types. There is no cardiac muscle there. Obviously there is no cardiac muscle here, but still we'll say we have a three types of muscle in that region. Now you'll be like, how come we have three types of muscle? Now guys, we have skeletal muscles which are coming from pharyngeal arches that you have right in front of you. Look at all these muscles that you have. These are the muscles derived from the pharyngeal arches. Muscles of mastication, facial expression, palate, pharynx and larynx, they are all skeletal muscle. But these skeletal muscles are a special group of muscle which are derived from pharyngeal arch. So one group we have the muscle derived from the pharyngeal arches. Then we have non-pharyngeal arch skeletal muscle. Like if you think of this area here, extraocular muscle and tongue muscles are also skeletal muscle. If I'm talking about the skeletal muscle, whatever skeletal muscles are covered in this are done. What are the remaining skeletal muscle we have in this area, guys? It says extraocular muscle and tongue muscle. They are also skeletal muscle, but those skeletal muscles are not derived from pharyngeal arches. You can see they are not in the pharyngeal arches. That's why those skeletal muscles are derived from somites. We call them the somatic muscles. They are skeletal muscles only, but we call them the somatic muscles here. So we got all these pharyngeal arch skeletal muscle, that is one group. Then we have somatic muscles, that is extraocular and tongue muscle. And then of course we have some smooth muscles in the head, neck and face also. Like we have smooth muscles in the eyeball, sphincter pupillae, ciliaris, all those are smooth muscles only. So talking about the muscles in total, before we go to the nerves, we should know the types of muscle. We can categorize the muscles in three groups. Skeletal muscles from where? From pharyngeal arches, right? That's one group, guys. Skeletal muscle from pharyngeal arches, which includes the muscles of mastication, facial expression, palate, pharynx, and larynx. Then we have the second group, that is the, again, skeletal muscles only, but these are skeletal muscles from somites. Now, what is somites? Don't bother about that. We'll discuss somites in detail in the embryology part, but you should know that somites or somatic muscles include which muscle? It is the extraocular muscles and tongue muscles. Extraocular and tongue muscles here. You already know what are the muscles from pharyngeal arch. Now we're looking at the skeletal muscles which are derived from somites, that is extraocular and tongue muscle. And then we have a third group of muscles which are smooth muscles. Well, that's the demand. We need to go to the supply. That's a demand, that you have to supply the muscles which lies in three different groups or three different categories. Pharyngeal arch muscles, then we have somatic muscles, and then we have some smooth muscles here. To supply three different types of muscle, I need three types of columns also. When we talk about, guys, column like general somatic efferent, special visceral efferent, general visceral efferent, columns. So we have three efferent columns, three motor columns, because the type of muscles are also three. So talking about the columns, we'll see that how three columns are there, and we have various afferent columns or sensory column also. Now we already understood that we need to supply the three types of muscles. Obviously we need three types of columns to supply them. So now understand that where the columns are coming from. So again, let me take you to some basics here, and then we'll try to connect the dots with each other. Guys, neural tube. Once again, we will be discussing details of the neural tube in the embryology, that how it develops, where it came from, what are the derivatives and everything. But let's say you're looking at a transverse section of a neural tube. What you'll see that the neural tube can be divided in two parts by a sulcus, and this embryological sulcus is called as sulcus limitans. Now there is a sulcus which divides the neural tube in two parts, that is called as sulcus limitans. It's a sulcus which limits the neural tube in two parts. Let's simply call it sulcus limitans. And how does it limit the neural tube in two parts? It divides the neural tube in two portions. As you can see, the one portion here, the ventral part here, this is called as the basal plate. This is the basal plate, and the dorsal part is called as the alar plate. So this part of the alar tube, which is dorsal to the sulcus limitans, it is called as the alar plate. And this portion of the neural tube is called as basal plate, which is the ventral part. This is called as a basal plate. Alar plate and basal plate. So you're looking at a picture of a neural tube. You can see a sulcus inside called a sulcus limitans, and that divides the neural tube broadly in these two parts, that is the alar plate and the basal plate. Now, just for 1 second, imagine you're not looking at a neural tube, guys. I want you to imagine this, that you're not looking at a neural tube, you're looking at a section of a spinal cord. Let's presume this is a section of a spinal cord. If this is a section of spinal cord, that means the alar plate is representing the dorsal horn and basal plate is representing the ventral horn, isn't it? Alar plate is toward the dorsal side, like a dorsal horn will develop from alar plate, and basal plate will give rise to ventral horn. And we know that in the spinal cord, the dorsal horn are sensory and ventral horn are motor. Dorsal horn are sensory, ventral horn are motor. That tells me that alar plate, that is the way to remember it, the alar plate is present toward the dorsal side and it is a sensory plate. In fact, it will give rise to the sensory cranial nerve nuclei. The sensory cranial nerve nuclei, all the sensory cranial nerve nuclei will develop from the alar plate. You think of any sensory cranial nerve nuclei, guys, trigeminal nuclei, nucleus of tractus solitarius, vestibular nuclei, cochlear nuclei. If a nucleus is for the sensation, it is going to develop from alar plate, period. Basal plate is present ventrally, and basal plate is a motor plate. So whatever nuclei will develop from basal plate, they are all motor cranial nerve nuclei. Now that's a question also, that which cranial nerve nuclei develop from alar plate and which one are developing from the basal plate. All you have to think about that which one is sensory and which one is motor. That's it. For example, let me throw some examples to you. If I say hypoglossal nucleus will develop from where, guys? Now hypoglossal nucleus is a motor nucleus. So obviously hypoglossal nucleus will develop from basal plate. If I say, for example, abducens nucleus or oculomotor nucleus, these are all motor nucleus, and motor nucleus will all develop from basal plate. But if I say nucleus which is sensory in function, like we have a sensory trigeminal nucleus, or we have a nucleus for taste sensation called as nucleus of tractus solitarius, or the nucleus like vestibular nuclei, these are all sensory nuclei. So they will all develop from where? The alar plate. So they in the MCQ form, they will give you 4 options and they will ask you, okay, which of the following nuclei developing from alar plate and which one is from the basal plate. All you need to decide whether it is sensory or it is motor, and you know the answer. Now let's try to correlate with this with something that we discuss in the medicine also. Let me just try to correlate this topic directly with the medicine part. Now guys, look at me. Let's say you're looking at a neural tube right now, and let's say my fingers are representing the alar plate and my thumb is representing the basal plate here. So let's say there's a neural tube here, my fingers are the alar plate and my thumb is a basal plate. Neural tube is going to give rise to the spinal cord, fine. The alar plate will give rise to the dorsal horn, the basal plate will give rise to ventral horn, all makes sense. And this space in between, that will form the central canal, right? Can you see that space over there? This space will form the central canal of the spinal cord. This will form the central canal of spinal cord. But if I think of the brainstem, this neural tube in the upper part will give rise to brainstem also. Now brainstem is not exactly like this, guys. Brainstem, obviously when the brainstem will form, there is a 4th ventricle which will develop inside the brainstem. And when the 4th ventricle develops, your neural tube needs to open up. So imagine the 4th ventricle is expanding inside and your neural tube will open up in this way. Now you can see what plate is going to what side now. The alar plate is the one which goes toward the lateral side. So when the 4th ventricle develops, the alar plate goes toward the lateral side and basal plate is the one which comes toward the medial side. That tells me if the alar plate has gone toward the lateral side, that means which nuclei are shifted toward the lateral side? The sensory nuclei. So that means your sensory nuclei will develop toward the, or they will move toward the lateral side, and most of the motor nuclei are toward the medial side. After development, some migrations will take place from here and there also. But all I'm saying is that majority of the motor nuclei are present close to the midline because basal plate is close to the midline, and most of the sensory nuclei are toward the lateral side. And see why this information is important for you people. I mean, let's say you get a question on any brainstem syndrome. A very random example, if I take like Weber syndrome or Millard-Gubeler syndrome or medial medullary syndrome, whichever it is. If a syndrome is going to affect the midline portion of the brainstem, these are all midline syndromes only. So the main loss the patient will show is a motor loss. Contralateral hemiplegia, third nerve palsy, facial palsy, abducens palsy, tongue paralysis, different syndrome, different kind of features here. But the common thing here is that the main loss, the major loss is a motor loss because it is affecting toward the midline. If a syndrome is affecting toward the lateral side of brainstem, like lateral pontine syndrome, Wallenberg syndrome, then you'll see the major loss is what? A sensory loss. Pain and temperature loss, from hearing loss, and other different type of sensory losses you will see. Which is a simpler explanation. When the neural tube opened up, the alar plate took all the sensory nuclei toward the lateral side, and basal plate took the motor nuclei toward the medial side. So let me go to the next step where we'll open this neural tube up and see how exactly it is going to look like. So guys, it's just a next step picture only. This is a neural tube opening up. Look at that. That's a picture where the fourth ventricle is developing inside. Right? It's a fourth ventricle being developed inside. And during the development of fourth ventricle, you can see the neural tube expanded this way here. Those arrows are showing you that how the neural tube opened up here. When the neural tube opened up, the sulcus limitans, which was exactly on the side, now this is shifted more anterolaterally. Sulcus limitans is shifted more anterolaterally. And that's the sulcus limitans, and that is shifted more toward the anterolateral side, resulting in the basal plate that you can see, which is close to the midline. Right? The basal plate is close to the midline and alar plate is toward the lateral side. Let me write on one side only so that other side we can use to draw and mark the nuclei. So this is the basal plate, agreed? That is a basal plate. And this one is the alar plate here. The basal plate go to the midline and alar plate is toward the lateral side. Let me take you back to the point, guys, when we said, okay, what are the types of muscles we have? We have three types of muscle. Skeletal muscles from pharyngeal arches, skeletal muscles from the somites, and we have the non-pharyngeal arch and the non-somatic muscle, that is smooth muscles basically. And to supply them, we need three types of nuclei or three types of columns. So in the basal plate, the three efferent columns, or you can say the three motor columns, will develop because we need to supply three types of muscle. So it's a simple and straight explanation, guys. We need three types of muscle to be supplied. So we have three types of motor columns also. Now something very basic, guys. What's the difference between a column and a nuclei? When I say column and nuclei, what's the difference? Look, when we talk about the similar kind of nuclei arranged in one line, for example, extraocular muscles are supplied by third nerve, fourth nerve, and sixth nerve, right? 3, 4, and 6. 3, 4, and 6. So in the brainstem, 3, 4, and 6 nuclei that develop in the single line only. And that single line is called as a column. Third nucleus is separate, fourth is separate, sixth is separate. They all are separate from each other. They are like detached from each other here. But they are all present in one single line, and that is called as a column. Arrangement of the similar kind of nuclei in one line is called as a column. So when you see the same type of nucleus in one line, that is called as a column. And right now you're looking at the three efferent columns in this picture. The very first efferent column here is the GSE. We'll come to the full form. I wanted to just write it with me. Then we have SVE. And then we have this column that is called as a GVE. The sequencing is very important. And for the questions, arrange the sequence, the following column in the floor of fourth ventricle. If you know the first three, then it's piece of cake. That's nothing. GSE, SVE, GVE. Let's take them one by one, break it down, and understand the meaning of these columns, guys. So how about we start with the first one? The first column, it says GSE. What GSE stands for? The GSE stands for the general somatic efferent. Efferent, obviously motor column, so the efferent, general somatic efferent. And the moment I say the word general somatic efferent, my eye catches the word somatic in it here. In the general somatic efferent, the somatic is the word that you need to catch, okay? Somatic. Somatic, guys, which muscles are somatic? Well, this is the column to supply the extraocular muscles and tongue muscles. The column to supply the extraocular muscles and tongue muscle, that's the thing about the GSE column. General somatic efferent. The word somatic will tell you about the extraocular muscles and the tongue muscles. You know these are skeletal muscle, but these skeletal muscles are derived from the somites. So that's the only function of this column, to supply the extraocular muscle and tongue muscle. That we will see. We'll come to that. The very next column we wrote there, guys, that is SVE column. SVE. Well, SVE stands for the special visceral efferent. That is a special visceral efferent. And when I say the word special visceral efferent, the special viscera, the specialized viscera, guys, special viscera. This is actually a misnomer here, and you will see that in the books like Gray's Anatomy, they use the term branchial for it. A branchial efferent. They call this column as a branchial efferent. Either you call it special visceral efferent, or in place of the special visceral efferent, you can use a term branchial. Branchial came from where? Branchial arches. That means this column is a pharyngeal arch efferent. That means it is going to supply those muscles which are derived from pharyngeal arches. So the function of this column, guys, branchial efferent column, is to supply the muscles derived from pharyngeal arches. It is the column to supply the muscles from pharyngeal arches, and I'm pretty sure that you remember which muscles are derived from pharyngeal arches. Muscles of mastication, facial expression, palate, pharynx, and larynx. Palate, pharynx, and larynx. Right? So the first column is for the extraocular and tongue muscle. These are the somatic muscles. The column name is general somatic efferent. Then we have special visceral efferent, special viscera. It's branchial arches. So branchial efferent, it supplies the muscles derived from the pharyngeal arches. Which brings us to our third column, that is GVE column. Well, the GVE column is for what? It is general visceral efferent, guys. Now the column name is a general visceral efferent. Now when I say general visceral efferent, what I'm looking at, I can understand the meaning of general visceral efferent by looking at the previous two columns. Now what do you think, what is the common between the first and second column, guys? What do I see common here and here in these two? The common thing in these two columns is that they are supplying these skeletal muscles. They are the columns to supply these skeletal muscles. Whether it's a skeletal muscle from pharyngeal arches or it's a skeletal muscle from somoid, but skeletal muscles. That means the only efferent column we have now, it is for obviously what muscles? The smooth muscles. So this is the only column left, guys, and this is going to supply the smooth muscles. And not only smooth muscle, it is a column to supply the glands as well. It's a column for supplying the smooth muscles and the glands. It supplies the smooth muscle and gland. Whatever, lacrimal, the parotid, submandibular, sublingual, nasal, all the glands are supplied by this column only. Now, how it is done, we will see that. I first want all of you to understand the meaning of these columns. The more you understand the basics here, I'll tell you, your life in the rest of the part will get easier only. So it's imperative to understand the meaning of what is general visceral efferent, special visceral efferent here. If you try to mug the name of these columns and what nuclei will come under them, that is not be very helpful, honestly. So the more you understand it, it will be like easily palatable. In fact, what I'm trying to tell you here, do not emphasize right now on the learning. If you don't remember what is the sequence of these columns as of now, doesn't matter. What matters to me that do you understand the meaning of the column? When I say general somatic efferent, you should know, okay, I need to catch the word somatic in this. When I say special visceral efferent, I know special viscera is a misnomer. It's branchial arches. So it is going to supply the muscles of pharyngeal arches. And obviously the third column, apart from this, the only column left here, it is for what muscles? Smooth muscles and glands. Right? So it's just about the understanding the columns first. We will discuss all details of these columns. You will see that. Okay, let me take you back to the table again, guys. Now this is the efferent column. What about the afferent column? When we talk about afferent columns are also 4 in number. Now afferent columns are not 3 in number, there are 4 in number. That's different here. 1, 2, 3, and there is a 4th column also. Efferents are 3, but afferents are 4. Afferents are 4. So when you look at the afferent column, you will see that the nomenclature of the afferent column is extremely simple. I mean, you should never get it wrong when it comes to the column and the sequencing, because you will get the hint from the efferent column only. Now understand this. This is GVE you're looking at here. Just let's go with the mirror image. The GVA will be here. This is SVE. SVA will be here, A, afferent. And this is GSE. The GSA will be here. So it's like a mirror image. You just need to flip it. Okay. I'm not saying that for this GSA, this is not GSA. No. You have to flip it. Basically for this GV, this is the one. For GV, you have a GVA, SVA. And for the GSA, this is GSA here. Just make a mirror image, guys. So the first afferent column that you'll come across when you're going from medial to lateral, this is a GVA column, followed by SVA, followed by GSA, and we still have one mystery column after that. We'll come to it. Just leave it for now. I want you people to understand the column before you write the name here. So let's go with these three first, the GVA, SVA, and GSA. Let's go with these three, and then we'll find out what is the fourth one which is still waiting to be named. GVA, SVA, and GSA, right? So this time we are talking about the afferent columns. The first is GVA, then we got SVA, then we have GSA, and there is a fourth one also. We'll come to that. Let's follow the same drill. GVA stands for general. There is general visceral afferent. GVA is general visceral afferent, and SVA stands for the special visceral afferent. SVA stands for the special visceral afferent. These are afferent columns, obviously, so it's all afferent here. And we'll come to GSA also. Just let's go with the first two guys. First and foremost, and very, very important to understand, please do not compare the efferent columns to afferent columns. If you're trying to understand the meaning of the afferent column based on efferent column, that's a big mistake that you'll do, and you will never ever get a right answer for that. See, what I'm trying to say, you got the hint for the names. That's it. That is it. Do not think about the columns, the meaning of the column based on the afferent. Like, it's like if I know GVE, it doesn't mean you know GVA also. No, they are two different stories altogether. Why? See, GVE is to supply what? Smooth muscles and glands. Does it mean GVA is carrying the sensation from smooth muscle and gland? No, that's not how we look at it here. See, how to look at the afferent column? First of all, just wipe the memory of the efferent column completely, because we are not going to look at them the same way. In the afferent column, the very first word is what? Either the first word will be general or it will be special. There are only two possibilities. The first word could be either general or special. Whether you have the next column or even after that here, the first word is either general visceral, general visceral, general visceral. The first word always tells you about the type of sensation. The first word is about the type of sensation. Like, is it a general sensation or is it a special sensation? General sensation like pain, temperature, touch, pressure, proprioception. These are all general sensation only. All these are general sensation. But when I say special sensation, it comes like taste is a special sensation, vision is special, olfaction, hearing and balancing. All these are special sensation. So whenever you're looking at the first word, it is just telling you about the type of sensation, just the type of sensation. The second word will tell you that where the sensation is coming from. The second word, guys, that is telling you about the source. Like the second word you're looking at here, viscera. Again, it is like visceral. Second word, again, there are two possibilities. Either we have a visceral or somatic. Visceral, somatic, visceral, somatic. The second word is only two possibilities are there, visceral, somatic. So second word is basically telling you about the source. Type of sensation and the source. Type of sensation and the source. So guys, whenever you're looking at the afferent column, always look at like this here. The first word is going to tell me, okay, what type of sensation am I talking about? And the second word will tell me that where the sensation is coming from. Is it coming from a viscera or is it coming from a somatic structure? Let's take an example. Let's say you're having a coffee. The temperature of a coffee is what kind of sensation? It is a general sensation. I mean, whether it's a hot coffee or cold coffee, whatever sensation you're feeling on the tongue, that hot and cold sensation is general sensation. And that general sensation is going from the tongue. Tongue is a viscera. So that will go into which column? The GVA column. General sensation from the viscera. A general sensation. Even if you bite your tongue, like if I accidentally bite my tongue, that is also a general sensation going from the tongue, will go into the GVA column. Pain is a general sensation. But when I talk about the coffee, the taste of the coffee, how the coffee is, that taste of the coffee is a special sensation, and that will go into which column? SVA. Special sensation from viscera, that is a taste sensation. Okay. So guys, when we say GVA, general visceral afferent, we are talking about the general sensation from viscera. General sensation from the viscera. Remember, it's viscera, it's not the body wall. This sensation is not coming from the skin or the muscle or periosteum. It's coming from the viscera. And when I say SVA, SVA means special sensation from the viscera, and you will see a catch here, the special sensation from viscera, and what is included in the special sensation of viscera is only taste. Now, don't be surprised, my friends, if I say taste is the only special sensation coming from viscera. There are I would say, a little controversy on that. Some says taste is also there, olfaction is also there, but I'll go with the Gray's Anatomy in this. The special sensation from viscera is only taste. Taste is the only special sensation coming from viscera. I'm not saying that taste is the only special sensation. Please mark my word carefully, guys. I'm not saying that taste is the only special sensation. Olfaction is also special. Vision is definitely special. Hearing and balancing is also special. But those sensations are not coming from the viscera. They are derived from the structure which are not endodermal. olfactory mucosa, retina. If you think of retina, guys, coming from neuroectoderm, internal layer is derived from otic capsule, which is again ectodermal. So other sensations, they are special sensations, but they are not derived from viscera. Now, I want you people to think about this and then answer this question to yourself, that when I say special sensation from viscera, the taste is occupying that. Okay, done and dusted. Taste is all about SPA. Okay, what about the other special sensation? Olfaction, vision, hearing and balancing. Now they will go into which column? So first, the first word, we know it decides the type of sensation. So when I'm talking about the olfaction, vision or hearing and balancing, I'm always obviously talking about special sensation. So the first word is special. Special. Second word, source, where it is coming from. Now these sensations are not coming from viscera, they are coming from somatic structure. I told you the second word is either visceral or it is somatic. So that's why the second word will be what? Somatic. And obviously we are discussing what column? Afferent column. So the name of the column will be special somatic afferent. Special sensation coming from somatic structure. Special somatic afferent. And that is the only column left to be marked here. That's why we have an extra column, guys. Look at this special column here. That is called as a SSA column. The column is SSA. Please mark the SSA column in the diagram. Special somatic afferent. The column here is SSA. That stands for, that is SSA, special somatic afferent. Let me write the name of this column first. That is the special somatic afferent. That is special somatic afferent. And just to tell you, in the special somatic afferent, what comes under the special somatic afferent? Olfaction, vision, hearing and balancing, you can say. Olfaction, vision, hearing and balancing, guys. Olfaction, vision, hearing and balancing, they all come under SSA column. SSA column. Okay, let's keep this column on a hold for a second. I'll discuss more details about this SA column. We'll come to that. But first, let's go back to the sequence, guys. We talked about the first column, which is about the general sensation from viscera. Now, I told you it could be anything. And when we said the temperature of a coffee, general sensation. You bite your own tongue, pain sensation, general sensation. If I say I had a lot of lunch today and I'm feeling my stomach is distended, that feeling of bloating, that feeling of distension of stomach is a general sensation. And it's coming from the viscera. So general visceral afferent, that will also go into the GVA column. When you think of SVA, special visceral afferent, it's just about taste. Taste sensation, no matter where the taste is coming from. Taste coming from the tongue, anterior 2/3 of tongue, posterior 1/3 of tongue, or the taste is coming from the pharyngeal wall. Whichever nerve is carrying the taste, ultimately they will land into which column only? The SVA column. And then we just said we have a very special column called as SSA column, that is special somatic afferent. All those special sensations which are not coming from viscera, which includes the vision, olfaction, and hearing and balancing. We'll come to that. Now, let me go in a sequence to the very next column, and in fact, a very important column that is called as a GSA. And GSA stands for General Somatic Afferent. It's a general somatic afferent, guys. The column is a general somatic afferent. Okay. What does it implies? When I say general, obviously the sensation is what type? General sensation. The second word is what? Somatic. That means this time the sensation is not coming from viscera, it's from the body wall. It's a general sensation coming from body wall. Same, pain, temperature, touch, pressure, but coming from the body wall, guys, not coming from viscera. And the finest example you can think of, the GVA column, the nerve which is the finest example here is the trigeminal nerve. My trigeminal nerve is taking the sensation from the face, different type of sensation. Olfactory nerve, ophthalmic nerve will supply the forehead skin, maxillary nerve will supply the skin in this area, maxillary nerve, mandibular nerve will supply here. We will discuss all these nerves in detail. But the three nerves, the three branches of trigeminal nerve are carrying all general type of sensation from face. Pain, temperature, proprioception, touch, vibration, any kind of sensation from face, they are carried by the trigeminal nerve. So one of the finest example that you will see in the GSA column, general somatic afferent, is a trigeminal nerve, which I will tell you eventually. But for now, just write, it is a column which is receiving the general sensation from body wall. Not from the viscera, from the body wall. General sensation from the body wall. General sensation from body wall. I will revise all the columns for you, but before that, Look, let me just finish off the last column again, guys. SSA column. Now, when I say SSA column, there are three nerves which are coming. There are three sensation in there. Olfaction is there, vision is there, hearing and balancing, guys. See, what is the catch in this? Olfaction, vision, and hearing and balancing. If the question asked to you is that what nerves carry the SSA type of sensation? Nerves which are responsible for carrying the special somatic afferent kind of sensation. So olfaction is by the first cranial nerve, that is the olfactory nerve. Vision is by the optic nerve. And hearing and balancing is by the vestibulo-cochlear nerve, 8th nerve. First nerve, second nerve, and then we have 8th nerve. But if the question says what nuclei come under this column, not the nerve this time, if I say nuclei, now that's a difference, guys. The question is changed. It's not about the nerve, it's about the nuclei. So I need to know that the olfactory nerve, do we have any cranial nerve nuclei for olfactory nerve? Well, no. Olfactory is the shortest cranial nerve. It starts from the olfactory mucosa. It goes through the cribriform plate and just goes into olfactory bulb. Game over. Olfactory nerve is a very short nerve. So that means there is no nuclei for the olfactory nerve. Does optic nerve is having a brainstem nuclei? No. Optic nerve also makes an optic chiasma. It makes an optic tract, and then it ultimately projects into the visual cortex, the striate cortex. So again, there is no nuclei. There is no brainstem nuclei for that. Answer is again no. But do we have cranial nerve nuclei for 8th nerve? 100%. We have a nuclei for 8th nerve in the brainstem called as a vestibular nuclei and cochlear nuclei. Now we have a nuclei for that. We got a nuclei called as a vestibular and cochlear nuclei. Multiple nuclei are there. It's not one or two. We have multiple nuclei for vestibular and cochlear nerve. So vestibular nuclei and cochlear nuclei which are present in the brainstem. Now see how this question is changed, guys. If the question is asked to you, which nerves come under SSA column? Nerves. Then I will say, okay, first is there, second is there, 8th is also there. All kind of SSK kind of nerve only. But which nuclei come under SSA column? Then the only answer is what? Vestibular and cochlear. There is no nuclei for first nerve. There is no nuclei for second nerve. So the answer is only 8th nerve nuclei comes under SSA column. They come under SSA column. Okay. Let me take you back to this picture. Now, as based on one of the recent question only, which is about arrange the following cranial nerve columns in the floor of fourth ventricle from medial to lateral. Understand the entire question, guys. Arrange the following cranial nerve columns in the floor of fourth ventricle from medial to lateral. You are looking at the fourth ventricle. This is a floor of fourth ventricle. And in the floor of fourth ventricle, when I go from medial to lateral, that's the arrangement of the nuclei. Now, it's a choice of examiner. They can ask you from lateral to medial also, but the question given was from medial to lateral. So please be careful while you're reading the questions like these. So from medial to lateral, when you go, we have all these nuclei present in the floor of fourth ventricle. The first column, GSE, SPE, GVE. I told you if you know the first three, then you know the next three. It's just a mirror image only. So we have a GVA, SVA, and GSA. And the one odd column, the SSA, is a little odd from out of these columns, and that is lying at the end. So if the question is only about the arrangement of nuclei, I think you should never get it wrong. You know the first three, you automatically know the next three, which is like a mirror image, and the very odd column, the SSA column, lies at the end. But if you go into more detail of that, guys, GSE, what GSE stands for? General Somatic Efferent. The word somatic is for what? That is for the extraocular and tongue muscle. The somatic muscles are extraocular and tongue muscle. So this column supplies the extraocular muscles and tongue muscle. SVE, Special Visceral Efferent, that is to supply the muscles of pharyngeal arches. It's a pharyngeal, branchial arch column. And the common thing between the first two columns is that both are supplying the skeletal muscle. Don't forget that both the columns are to supply the skeletal muscle. See, that's a common thing between the two columns. And that's why the third column that we have is for the smooth muscles and glands. GVE column is for supplying the smooth muscle and gland. Now, whatever smooth muscle and gland they are, we'll talk about the smooth muscle like sphincter pupillae, ciliaris muscle, parotid gland, submandibular gland, lacrimal gland. All glands and smooth muscle will be supplied by this column. We'll see that. Then we have afferent column, GVA, SPA, GSA, and SSA. And I told you the way we look at the afferent column is entirely different. The first word always tells you about the type of sensation. So when I say GVA, it's a general sensation, and the second word tells you about the source where it is coming from. General visceral afferent. General sensation from viscera could be anything. So any pain sensation, let's say coming from the lung region. General sensation coming from viscera. I told you distension stomach coming from the intestine. General sensation. The temperature of the coffee, I give example, general sensation. Like, and then we have SVA, special sensation from viscera, but the only special sensation from viscera is what? Taste. Taste is the only special sensation which will be from the viscera. So SVA column will only have the nuclei which is responsible for taste sensation. Then we have GSA. GSA is what? General somatic afferent. General sensation, the first word is general sensation from somatic structure, non-viscera. It could be skin, it could be periosteum, it could be muscle. So like I told you, the best example you can think of is a trigeminal nerve, because your trigeminal nerve take the various kind of sensation from face, pain, temperature, touch, pressure, and that is all coming from body wall, GSA. And finally, the very last one and the little odd column here, that is SSA, special somatic afferent. The sensations are special, but they are coming from the somatic structure. That means olfaction, vision, hearing and balancing, all these sensations are coming from the areas which are not derived from endoderm. So basically these are somatic sensations here. Somatic sensation, special sensations coming from somatic structure, I should say. So vision, then olfaction and hearing and balancing. But out of all these three sensations, the one which is having a nuclei in the brainstem is vestibular cochlear. Vestibular cochlear. So guys, this is about the arrangement of the cranial nerve nuclei in the floor of fourth ventricle. Now again, to tell you, do not emphasize too much on remembering the names of the column for now. You will understand it, you will remember it, I promise you. You just need to remember the meaning of the columns here, because the more you understand the meaning, it's easy for you to understand, okay, what nerves will be related to it, what they are going to supply. That's why more important than the names, you need to understand their meanings. Let's take all these columns, all the 7 columns, and put them in the brainstem, and let's find out that what nerve nuclei lies under these columns. Because we know what is the difference between the column and nuclei, guys. I told you individually we have nuclei, and the collection of the same kind of nuclei is a column. So when I say general somatic efferent column, this general somatic efferent column must be having various nuclei which is having something in common between them. Similarly, special visceral efferent column will have a various nuclei present at different level, but they have something in common. That's why they're placed together only. So guys, I hope you understood the meanings of these columns. Let's take all these columns and put them in the brainstem. So here we go, guys. This is the very first column where we'll just write down the 3 parts of the brainstem. Let's say this is the midbrain. Some of the nuclei will be present in the midbrain. The pons, and then the medulla oblongata. The 3 parts of the brainstem: midbrain, pons, and medulla oblongata. Midbrain, pons, and medulla oblongata. And let's place the column, guys. The first column, we know that if we are starting from medial to lateral only. So if I'm going to go with these here, the first column here is, what is the first column? That is GSE column. The column here is a GSE, general somatic efferent. That was the very first or most medial column. The next column is what? SVE. The second column is SVE. Let me just put a line for that also. That is SVE column. And then we have another column, that is the very next column is what? That is a GVE column. This column here is a GVE. I'm writing all the column in the sequence only, right? Going from medial to lateral. Then we have GVA, the SVA, and all those here. Now, just a little catch here, and I'll explain that what is the reason for that. The very next column, the very next afferent column is what, guys? The very next column is GVA. Obviously, for the corresponding to that is GVA, and SVA column will be the next one. But I wanted to write down the next 2 columns together only, and there is a reason for that. Just do it. GVA and SVA. We are writing GVA and SVA together. Please do the same. Followed by, what is the next one? Then we have a GSA, general somatic afferent, GSA. And finally, we have another column, that last one, that is a SSA column. That is a SSA column. Please do check the list by yourself. These are the columns present in the sequence. The only thing is we kept GVA and SVA together and explain that to you. Now, this is the time to understand that we understood the meaning of the column, but what lies inside that column, that we need to now understand. And we also need to see that nuclei is present in which part of the brainstem. For example, when I take you back to the GSE, I hope you remember the key word in the GSE was S, that is somatic. The somatic muscle, this reminds you of what muscle? Extraocular muscles and tongue muscle. Extraocular and tongue muscles. Now you know extraocular muscles are supplied by what nerves? Third nerve, fourth nerve and sixth nerve. 3, 4 and 6. 3, 4 and 6 will supply all the extraocular muscle. And tongue muscles are supplied predominantly by hypoglossal nerve. 12th. Hypoglossal nerve is 12th nerve. So in this column we have 3, 4, 6 and 12. 3, 4 and 6 supplying the extraocular muscle and 12 nerve will supply the tongue muscle. Look, 3, 4 and 6. 3 and 4, third and fourth nucleus. Third nucleus and fourth nucleus are present in the midbrain. Sixth nucleus is present in the pons. And then we have this big nucleus present in the medulla oblongata, that is a hypoglossal nucleus. That's the arrangement of the nuclei exactly in one line, and they're all column, guys. So what is that? This is the third nucleus. This is fourth nucleus, the trochlear nucleus. Here we got the abducent nucleus, and this is the 12th hypoglossal nucleus. This is called as a GSE column. That's about the GSE column. General somatic efferent column. Somatic means supplying the extraocular and tongue muscle. Extraocular muscles supplied by 3, 4 and 6 nerve, and tongue muscle by 12th nerve. That's why you see 3, 4, 6 and 12. Important thing, 3 and 4 are in the midbrain, 6th in the pons, and 12th in the medulla oblongata. And this is very, very important, guys. Level of nuclei is something so important that especially in the neuroanatomy and when we discuss the brainstem syndromes, you will realize that why the level of the nucleus is so important. Because the nerve and the nuclei will help you differentiate one syndrome from another. If I just give you one random example, like a patient's come with a hemiplegia of the left side, upper limb, lower limb paralysis there is a pain and temperature loss from the body, and other features are also given. You know, these features can be in multiple syndromes. Wallenberg syndrome can show the features like this. Medial medullary syndrome can show features like these. Millard-Goebbeler syndrome, Fovili syndrome, Weber syndrome. There are multiple syndromes possible in which these features can be there. What is going to help you to identify or narrow down is the nerve. For example, if I say there is a left side hemiplegia with right side facial palsy. The moment somebody say right side facial palsy, okay, what comes to my mind? Okay, facial nerve is involved. And I know where facial nerve is coming from, where pons, the nucleus is in the pons here. We'll discuss that here. Or if I go with example based on what is marked right now, if I say the patients come with a hemiplegia of the left side, and on the right side there is a sixth nerve palsy. Now we know sixth nerve is coming from where? Pons. So now your brain will say, okay, this might be a pontine syndrome. So that's how you're eliminating the medullary syndrome and midbrain syndrome in that ways. If the same case is given and the question says the patient is having a tongue paralysis, then you start thinking about hypoglossal nucleus or nerve, which is coming from where? Medulla oblongata. Then you're thinking about medullary syndrome. So knowing the cranial nerve nuclei, where the cranial nerves are coming from, well, that's important, guys, because this is really going to help you to understand that how the brainstem, how to differentiate one brainstem syndrome from another. You will see that. So third and fourth in the midbrain, sixth in the pons, and 12th in the medulla oblongata. The next column is SVE column. SVE, guys, special visceral efferent. The special visceral efferent column is to tell you about the pharyngeal arch. Nerves supplying the pharyngeal arch. The nerve for the first pharyngeal arch is mandibular nerve. And look at this, motor nucleus of mandibular nerve, it lies in the pons. Motor nucleus of mandibular nerve lies in the pons. That is a nerve for first arch. What is the nerve for the second arch? Facial nerve. So facial nucleus lies in the pons as well, just below the mandibular. So you're looking at the nerve for the first arch, you're looking at the nerve for the second arch. And then you will see a collective nucleus, again a big nucleus present in medulla oblongata. All these nucleus that you notice present in the medulla oblongata are long nuclei. This nucleus here, which is a collective nucleus for ninth nerve, because ninth is the nerve for the, ninth is nerve for what arch? Third arch. 10th nerve, which is the nerve for both fourth and sixth arch. And maybe to your surprise, it is also the nucleus for 11th nerve. I'll tell you what 11th is that. That's actually cranial accessory. And this nucleus, collectively this nucleus is called as the nucleus. This is called as a nucleus ambiguous. The nucleus is called as a nucleus ambiguous. Guys, let's discuss more about this nucleus ambiguous. First the name here. So nucleus ambiguous is a common nucleus for the 9th, 10th and 11th nerve. It's a common nucleus for 9th, 10th and 11th nerve. Before I tell you more about the nucleus ambiguous, see, in this column, what makes sense and what doesn't make sense here. Mandibular is a nerve for the first arch. Okay, so it should be there because this column is for pharyngeal arches only. Facial nerve is the nerve for the second arch. Again, it makes sense. Glossopharyngeal for third arch, fine. 10th nerve is a nerve for fourth and sixth arch, fine. Then where this 11th nerve came from? Because we don't say that 11th nerve is the nerve for pharyngeal arch, isn't it? 11th nerve is not supplying the pharyngeal arch. When we talk about pharyngeal arches, 11th nerve is not talked about. Then how come we have 11th nerve nuclei also present in the SVE column, which is only for pharyngeal arch? Now let me tell you guys, 11th nerve, the cranial accessory nerve. First of all, this is cranial accessory, not spinal accessory. This cranial accessory nerve, it does supply the muscles of palate and pharynx also. That means it is also supplying the muscles of pharyngeal arches. But the only reason that we don't give credit to 11th nerve, because we don't see that happening. 11th nerve and 10th nerve, they both comes out of jugular foramen. I hope everyone agrees to me. We all know jugular foramen, guys. The jugular foramen gives passage to 10th nerve and it also gives passage to the 11th nerve also. But the moment this cranial accessory nerve comes out of the jugular foramen, it joins with vagus. So from here onwards, from the jugular foramen onwards, whatever 11th nerve is going to supply, it is going to supply via vagus only. So it will look like that vagus nerve is supplying the muscles of palate, it's supplying the muscles of pharynx, but actually it's the cranial accessory nerve running along with the vagus nerve and then supplying the muscle of palate and pharynx. And this arrangement is called as a vago-accessory complex. It's the vagus and accessory nerve complex together. We call it a vago-accessory complex. Let me write that point for you first. Look, it's about the muscles of palate and pharynx. Muscles of palate and pharynx. Muscles of palate and pharynx, not larynx. I'm not talking about larynx, only the palate and pharynx. Muscles of palate and pharynx, they are supplied by, as I said, by cranial accessory nerve, but via vagus. Obviously, they're using the vagus nerve to reach the destination. So it's cranial accessory via vagus. And this arrangement is called as vago-accessory complex. This arrangement is called as, guys, that is vago-accessory complex. From now onwards, we'll call it VAC, in short, VAC, vago-accessory complex. This lead to a question, the leading question here is, okay, so 11th nerve, that's why the cranial accessory nerve is also counted in the nucleus ambiguous, because it is also supplying the muscles of pharyngeal arch, although it is having a hidden function, but it is still there. What will happen if there is an injury to nucleus ambiguous? Such an important nucleus, it's a nucleus for 9th nerve, 10th nerve, 11th nerve. Now, what will happen if there is an injury to nucleus ambiguous? Well, in case of injury to nucleus ambiguous, what will happen? All the muscles of palate, pharynx and larynx of one side will be gone. 9th nerve, 10th nerve and 11th nerve, all three are gone. So there will be a ipsilateral bulbar paralysis. There will be ipsilateral bulbar paralysis, guys. Not pseudobulbar, ipsilateral bulbar paralysis. That is one thing. And as you can see, 9th and 10th nerve, 9th and 11th nerve, 9th and 10th nerve are responsible for gag reflex also. So there also will be the loss of gag reflex on that side. There will be a loss of gag reflex as well. So injury to nucleus ambiguous, such an important nucleus, guys. Injury to the nucleus ambiguous will cause ipsilateral bulbar paralysis. The muscles of palate, pharynx and larynx of that side will undergo the flaccid kind of paralysis, that is a bulbar paralysis, and that also lead to the loss of gag reflex. The gag reflex. So this is a little about the nucleus ambiguous. I hope you understood that why nucleus ambiguous is so important. And why 11th nerve is also placed in this column here. The column is only for pharyngeal arch, but 11th nerve is also supplying the muscles of pharyngeal arch, but via vagus. That's why we don't give a credit to it. We generally don't say cranial accessory nerve is supplying the muscle of palate here. We say cranial accessory using the vagus nerve or via vagus nerve supplies the muscles of palate and pharynx. Right. Now you know the first and second column, guys. The first column is for the somatic muscle. Second column is for the pharyngeal arch here. But what was the common thing between the first and second column? Both these columns were supplying the skeletal muscle. And that brings to our third column, that is a column for smooth muscles and glands. The smooth muscles and glands. Okay, let me name the nuclei here and then we're going to discuss this column separately in detail. There is a nucleus present in this column that is called as Edinger-Westphal. I'm writing in short only, that is EW, Edinger-Westphal nucleus. Then we got two nuclei which are present in the pons. There are two nuclei present in the pons. We call them salivatory nucleus, guys. We got a superior salivatory nucleus and there is an inferior salivatory nucleus for salivary gland. Inferior salivatory and superior salivatory nucleus. Just write in short only. I'm going to discuss it separately with you. And then we have again a big nucleus present in medulla oblongata. This is called as the dorsal nucleus of vagus. This is the dorsal nucleus of vagus. Dorsal nucleus of vagus. Just write the name and the location of these nuclei and let's discuss it separately. It's a very important column. It deserves to be discussed separately. So we have a Edinger-Westphal which is present in the midbrain. I can see superior salivatory, inferior salivatory which are present in pons, and we can see the dorsal nucleus of vagus which is located in medulla oblongata. So they all lie in the GVE column. They all lie in GVE column. So guys, let me take this column separately here and then we'll see what this column has to offer. Okay. So the column says GVE, the general visceral efferent. The nuclei we are talking about, let me put those nuclei once again here. The first one there was the Edinger-Westphal, that is EW, Edinger-Westphal nucleus, followed by the two salivatory nucleus, the superior salivatory and inferior salivatory. There is a superior salivatory nucleus, and then we got this inferior salivatory nucleus, and then this big nucleus which is situated in the medulla oblongata. There is a dorsal nucleus of vagus, right? That's a dorsal nucleus of vagus. Stay with me in this, guys. So this is the superior salivatory nucleus, inferior salivatory nucleus, and this is the dorsal nucleus of vagus. Okay. Let's understand that what these columns are going to do, what these nuclei present in this column are going to do. Edinger-Westphal, superior salivatory, inferior salivatory, dorsal nucleus of vagus. I told you this column is to supply what? Smooth muscles and gland. Now don't forget that point. The column is to supply the smooth muscles and glands. Okay. Edinger-Westphal, that's a nuclei. What is the nerve for Edinger-Westphal? The nerve for Edinger-Westphal is the third nerve, oculomotor nerve. Edinger-Westphal is the nerve for the Edinger-Westphal nucleus is the third nerve. And what Edinger-Westphal will do using the third nerve, it will go to some ganglion, will relay there. But let me just tell you in short, guys. The purpose of Edinger-Westphal is to go and supply some smooth muscle in the eyeball. And those smooth muscles are sphincter pupillae. This is to supply the sphincter pupillae and ciliaris. The sphincter pupillae and ciliaris. That's the column is for. That is for the sphincter pupillae and ciliaris. Superior salivatory nucleus and inferior salivatory nucleus. Guys, superior salivatory and inferior salivatory. Superior salivatory nucleus is a nucleus for the facial nerve. When I'll discuss facial nerve with you, I'll discuss this thing more in detail to you. And inferior salivatory nucleus is the nucleus of ninth nerve. It's one of the nucleus of the ninth nerve. So superior salivatory nucleus is one of there are multiple nuclei we have for facial nerve. We have multiple nuclei for the ninth nerve. This is one of them. Superior salivatory is a nucleus for facial nerve and inferior salivatory is one of the nucleus for ninth nerve. When it comes to salivary gland, the name of the nucleus and the function of the nucleus sounds a little opposite here. Because superior salivatory nucleus will supply the gland below and the inferior salivatory nucleus will supply the gland above. That means parotid gland is supplied by the inferior salivatory nucleus and submandibular and sublingual gland are supplied by the superior salivatory nucleus. So first, if I just think of only salivary gland for now, guys. So superior salivatory nucleus, it supplies the sublingual and submandibular gland. Sublingual and submandibular gland. And inferior salivatory nucleus is to supply the parotid gland. Inferior salivatory nucleus is to supply the parotid gland. Sublingual and submandibular gland, and inferior salivatory is for the parotid gland. But tell you something, superior salivatory nucleus is not only to supply the sublingual, submandibular gland, it supplies the nasal gland also, lacrimal gland also. Lacrimatory nucleus, sometimes it's a detached part of the superior salivatory nucleus, or sometimes it's this along with the superior salivatory nucleus only. So the another two important gland that I can write over there is a nasal gland, and the one on which the questions are asked, that is lacrimal gland. Lacrimal gland, guys, even lacrimal gland is supplied by the superior salivatory nucleus. Don't get carried away with the name of the nucleus. Don't think the name says salivatory nucleus, how can it supply lacrimal gland? actually lacrimatory nucleus, if it is present individually, separately, it's a detached part of superior salivatory nucleus only. So superior salivatory nucleus, it supplies submandibular, sublingual, and it supplies nasal, and especially lacrimal gland. Keep an eye on. That's a question asked, guys. Secretomotor fibers to lacrimal gland originates from superior salivatory nucleus. Whereas inferior salivatory nucleus is dedicated to supply what gland only? And that is parotid gland. Inferior salivatory nucleus, no question about that. That's only for the parotid gland. What about the dorsal nucleus of vagus? Dorsal nucleus of vagus goes without saying, it is a nucleus of vagus nerve, right? It's dorsal nucleus of vagus, so it's a nucleus of vagus nerve. And as you can know, guys, vagus is the only cranial nerve which goes beyond head and neck. When you think like that, out of the cranial nerves, the only cranial nerve which goes beyond head and neck and supplies the structure beyond head and neck, that is what? That is vagus nerve. So when it comes to the smooth muscles of the in the thorax, or smooth muscles in the abdomen, or gastric glands or esophageal glands, they are taken care of by the vagus nerve. So it's the vagus nerve responsibility to supply the smooth muscles and glands where? In thorax and abdomen. Smooth muscles and glands in thorax and abdomen. Right? So you can see that's overall what the GVE column is about, guys. General visceral efferent column is connected to some of these nerves. You can see it's a 3 nerve, 3rd nerve, 7th, 9th and 10th nerve. And these are the smooth muscles and glands which are being taken care of. We will discuss all these smooth muscles and gland again when I'll talk about the 3rd nerve, 7th nerve, 9th nerve with you. We'll come to that part. But here we got a broad idea about that, what the GVE column is actually for. Now let me take this discussion a little further before we go to the other columns here, because there are other questions need to be answered. Do you see some similarity, guys, here? The 3rd nerve, 7th nerve, 9th nerve and 10th nerve. Out of the 12 cranial nerve we have, these are the 4 cranial nerves which are doing a parasympathetic function. They're supplying smooth muscle and gland. Obviously, smooth muscle and glands are supplied by the autonomic nervous system. So that's why the 4 cranial nerves that you're looking at right now on the screen, that is 3, 7, 9, 10, guys, these 4 cranial nerves are called as parasympathetic cranial nerve. That's a question also, that which cranial nerves are parasympathetic in nature, and the answer is in front of you. These are 3, 7, 9 and 10. These are parasympathetic cranial nerves here. These nerves are supplying the parasympathetic, they're having a parasympathetic function of supplying the smooth muscle and gland. That is called as a parasympathetic cranial nerve. If the question is asked, which nerves are parasympathetic in nature? 3, 7, 9, 10. Which nuclei are parasympathetic? Edinger-Westphal, superior salivatory, inferior salivatory, dorsal nucleus of vagus. Which column is parasympathetic? GVE column is parasympathetic. Look, it's the same question only. It's just a different way of asking the same question again. If they ask you which nerve, which nuclei, what column, these are all parasympathetic. We are talking about the parasympathetic column itself. And they took this question a one step forward when this question was asked in the INI exam, that parasympathetic outflow is by what nerves, guys? When I say parasympathetic outflow, look at that. There are 2 types of outflows, there are 2 types of autonomic nerves coming out of the central nervous system. We have sympathetic outflow and we got a parasympathetic outflow. When it comes to the autonomic nerves coming out, when I talk about the autonomic nerves coming out, we have 2 types of outflow. There is the parasympathetic outflow and sympathetic outflow. I hope you know that the alternative name, guys. Parasympathetic outflow is also called as a craniosacral outflow. Parasympathetic outflow is also called as a craniosacral outflow. Well, why do we call it a craniosacral outflow? Because cranial nerves, some cranial nerves and some sacral nerves are parasympathetic in nature. When I say cranial nerve, you already know which cranial nerve I'm talking about, guys. That is 3, 7, 9 and 10. So the cranial nerve 3, 7, 9 and 10. 3, 7, 9, 10. These are parasympathetic cranial nerve. And which sacral nerves? The point is sacral. Which sacral nerves are parasympathetic? Well, the answer is again S2, S3 and S4. Let me add to the list here. That is S2, S3 and S4. And that's the parasympathetic outflow. These are the 7 nerves which are parasympathetic in nature, guys. They're taking care of the parasympathetic supply in the entire human body. The 7 nerve, 3, 7, 9. And look at this. 3, 7, and 9 will take care of mainly the head and neck part. 3, 7, and 9. 10th nerve will take the responsibility beyond head and neck, supplies the thorax, supplies the abdomen part here. And when it comes to the pelvic and perineal region, in the pelvis and perineum, it's a sacral nerve which are more having a more contribution to the parasympathetic supply. That is S2, S3, S4. So 3, 7, 9 will take care in this part. Vagus will go beyond and will supply the thorax and abdomen region. And when it comes to the pelvis and perineum, it's a sacral nerve, S2, S3, S4 nerve. So parasympathetic outflow. Sympathetic outflow. Sympathetic outflow, it is also called as the thoracolumbar outflow. Sympathetic outflow is also called as a thoracolumbar outflow. That means the thoracic nerves and lumbar nerves are sympathetic in nature. Which thoracic nerve and which lumbar nerve? Well, all thoracic nerve, that means starting from T1 to L2. T1 to L2 nerves, these are all sympathetic nerves, guys. I mean, they're having their other functions also, T1 to T2, T3, T4, all these nerves supplying intercostal spaces. T1 contributes to brachial plexus, but they have an additional function that they are sympathetic also. They're connected to sympathetic chain, and using the sympathetic chain, they can ascend and descend downward also, and can they do supply the entire body. The sympathetic supply to the entire human body comes from T1 to L2. So from T1 to L2, we have the nerves coming out, and they using the sympathetic chain, they reach above and they go downward also, and can come out from different level. That I'll tell you more about in the nervous system. So this is about the question, guys. The question asked was about the parasympathetic outflow, and that is 3, 7, 9, 10, S2, S3, S4. If they ask you sympathetic outflow, your answer will be T1 to L2. Let's fall back to the table here, guys. So in that, we discussed with the first 3 columns here. The first column, extraocular and tongue muscle. The second column, it is pharyngeal arches. The third column, smooth muscles and gland. Done. Coming to the next one, and we said, guys, in the afferent column, the first odd thing that you're looking at over there is a GVA and SVA are put together. Why we are writing GVA and SVA together? Because there is one nuclei which is doing both the function. There is a nucleus, there is a single nucleus which is carrying the general sensation from viscera, and the same nucleus is responsible for carrying the taste sensation also. And that's why we have to put both the columns together only. Look, there's a nucleus here which is present in the medulla oblongata. Again, quite a big nucleus in the medulla oblongata. And this is a nucleus which is GVA also and SVA also. And the speciality of this nucleus is there is nothing above, there is nothing below this nucleus. When you look at this nucleus, there is no other piece of gray matter present above, and there is no other piece of gray matter present below. And this is the nucleus which is alone here. And that's why it is called as a nucleus of Tractus solitarius. It's a solitary nucleus. It is called as a nucleus of Tractus solitarius, guys, NTS, the nucleus of Tractus solitarius. It is called as the nucleus of Tractus solitarius. Makes sense why we call it nucleus of Tractus solitarius. It's a solitary nucleus, nothing above, nothing below, nucleus of Tractus solitarius, in which the cranial part of this nucleus, when you look at the cranial most part of this nucleus, this is actually SVA. That means taste sensation will go to the upper cranial part, the gustatory part. Taste sensation goes into this one, in the cranial part here. And the general sensation from the viscera will come from the larger caudal part. If I take you back to the same example, the taste of the coffee was going into the SVA, but the sensation, the temperature of the coffee goes into the GVA column here. So we have upper cranial part, that is gustatory. Taste will go to the cranial part, and the general sensation will go to the caudal part. But don't forget, it is the only visceral nucleus, because the next two column we have is somatic. So when it comes to visceral sensation, it's not only about the tongue sensation, palate sensation, pharynx, esophagus, stomach, intestine. Directly or indirectly, these sensations are coming to this nucleus only. Nucleus of Tractus solitarius, the solitary nucleus, the nucleus which is alone, it is the visceral nucleus. It carries all the sensation from viscera. If it is a general sensation, it goes to the caudal part, which are many kind of general sensation. When it comes to special sensation, that is only taste, and that goes to the cranial part of this nucleus. Which brings us to our next column, guys, that is GSA column. Another important column from where the questions are expected, guys. GSA, General Somatic Afferent. Now again, just just think about the whole thing, guys. General somatic afferent. The column is responsible for general sensation, but from somatic structure, from body wall. And I told you the best example they can think of in this column is the trigeminal nerve. In fact, the nuclei present in this is called as a trigeminal nuclei only. Now look at the size of this nucleus, guys. We have a nucleus present in the midbrain. We have a part of this nucleus present in the pons. And then we have a part of this nucleus. It starts in the pons. It crosses the medulla oblongata. And it even goes to the spinal cord as well. Imagine, look at how big this nucleus is. So we have one part of this nucleus which is present where? It is in the midbrain. We'll discuss it separately, guys. This is a mesencephalic nucleus, by the way. Then we have one part of this nucleus which is present in the pons, the thickered part, which is called as the chief sensory nucleus. And then we have the portion of this nucleus which is after crossing the medulla oblongata, it goes to the spinal cord also. It reaches spinal cord. So we call it a spinal nucleus of what? Of trigeminal nerve. That's a trigeminal nuclei. I mean, collectively, I call it just trigeminal nuclei. I'm just writing trigeminal for now. This is a trigeminal nuclei, but having three parts. One in the midbrain, the pons, and then the longest part is starting in the pons only, then crossing the medulla, and even reaching the upper part of spinal cord. Even reaching the upper part of spinal cord. Well, when I say upper part of spinal cord, till where? Till the C2 level. It goes till the second cervical segment, guys. It reaches till the second cervical segment. So you can see it's a very, very big nucleus. Starting in the midbrain, then the pons, then medulla oblongata, and even reaching the upper C2 level of the spinal cord also. Okay, we'll discuss this nucleus in detail. That needed to be discussed in detail. But first, let me finish off this table, guys. What is the last column here? SSA column. That was a simple one. There were three nerves in this column. Nerves. Olfactory nerve, optic nerve, and then vestibulocochlear nerve. But when we say nuclear, because we're discussing about the nuclei right now, the only nuclei in this column is what? Vestibular and cochlear. So this is a column which is holding this vestibular and cochlear nuclei. Where are exactly vestibular and cochlear nuclei? Multiple nuclei are there, and these vestibular and cochlear nuclei are present at pontomedullary junction. Look where I'm pointing at, guys. This is the pontomedullary junction. This is where we have the vestibulocochlear nuclei. So let's presume that these are the group of the vestibular nuclei. There are multiple vestibular nuclei we have, and similarly we have dorsal, ventral, we have multiple cochlear nuclei also. So vestibular and cochlear nuclei present at what? Pontomedullary junction. Pontomedullary junction. So guys, these are the columns that we have, the GSA column, SV column, and I cannot emphasize more on this by saying that please understand the meaning of the column first. This part will get easier. If you don't try to understand the meaning of the column, these nucleus will trouble you. If not today, maybe tomorrow, when you have to try to understand the trigeminal nuclei, what is the function, and you don't know which column it lies in and what that column is actually for, then you will always have a problem with that here. Because you will see the variations, like, for example, the name of the nucleus is trigeminal nuclei. But does it mean only trigeminal nerve can come into it? No. Any nerve which is carrying GSA, any nerve which is carrying general sensation from body wall can come into it. It doesn't matter the name of the nucleus is trigeminal nerve. It doesn't matter at all. It says nucleus of tractus solitarius, taste sensation. It doesn't matter taste is carried by chorda tympani, taste is carried by glossopharyngeal, taste is carried by vagus nerve. Ultimately, taste fibers will land into this the nucleus of tractus solitarius. So knowing the meaning of the column is extremely important to know about the more details about of these nuclei here. Chalo, in that context, let us talk about this GSA column in more detail because there are multiple questions, direct questions from this GSA column alone. So let me take this GSA column separately. Okay, the GSA column, we said there are three nuclei in there. Look, the collectively we call it trigeminal nuclei. Collectively, this is a trigeminal nuclei. What you will see, the very first nuclei present above here, it is present in the midbrain, so we call it mesencephalic nucleus. Mesencephalic or mesencephalic, whatever you call it, mesencephalic nucleus, it is present in the midbrain. Then we have the next nucleus which is called as a chief or principal sensory nucleus. Chief or principal sensory nucleus. And then we have the next nucleus which is called as the spinal nucleus. The spinal nucleus. like 3 nucleus are there. These 3 nucleus are named separately because they have their separate function also, guys. When I say mesencephalic nucleus, mesencephalic, it is present in the midbrain. This nucleus is responsible for receiving the proprioception. This nucleus is responsible for receiving the proprioception. It's a nucleus to receive the proprioception. Chief sensory or principal sensory nucleus is a nucleus to receive the touch and pressure. It's a nucleus to receive the touch and the pressure. It's a nucleus to receive the touch and pressure, whatever kind of touch is that. And then we have a spinal nucleus which is responsible for receiving pain and temperature. Now, please understand one thing. When I say the type of sensation, it is regardless of which nerve is carrying it. Trigeminal nerve carrying the proprioception, fine. Trigeminal nerve branch will use this, the trigeminal branch and reach the mesencephalic nucleus. But if there is any other nerve which is carrying proprioception from a somatic structure, from a muscle, let's say muscle of mastication, anything, I'm just giving a random example there, that is also allowed to come into the mesencephalic nucleus. So again, do not be biased with the trigeminal name here. Trigeminal nucleus doesn't mean only trigeminal nerve is allowed to come in. It is about the type of sensation and what type of sensation, where they're coming from. Proprioception or pain, like for example, pain and temperature. If pain and temperature is coming from any area, for example, just which is supplied by the vagus nerve. If it is a body wall area and supplied by vagus nerve, and if the pain is coming from where, then vagus nerve is carrying the pain and temperature into the spinal nucleus. It's not the trigeminal nerve here. So knowing the meaning of the column and what type of sensation they're carrying inside is important, rather than just thinking about trigeminal nerve is the only nerve coming into it. Especially the mesencephalic nucleus out of this is having multiple questions asked in the previous year examination also, guys. Mesencephalic nucleus is a site for it is a site where the proprioceptive fibers will come inside. Now it is also the site for mesencephalic nucleus is also the site for, or you can say it is a site for jaw reflex. You can call it jaw reflex, or you can call it a mesenteric reflex. Masseter muscle, guys. It's a site for jaw reflex or mesenteric reflex. Because it is a site for proprioception, it is a center for the proprioception. So the jaw reflex center is this only, guys. For example, when you tap your jaw, for the jaw reflex, what you do, guys? You tap your jaw here with the hammer. You send the proprioception inside, and those proprioception goes into mesencephalic nucleus. And then mesencephalic nucleus will guide those sensation toward the motor nucleus, so that the reflex will take place. Your masseter muscle will contract here, right? And by the law of physiology, all the deep tendon reflexes are monosynaptic reflexes. Now understand this. All the deep tendon reflexes are monosynaptic reflexes. And to have a monosynaptic reflex, we need pseudo-unipolar neuron. That's a simple thing. Like the sensation will come inside like this from here into the mesencephalic nucleus, and from there it is directly oriented toward the motor nucleus of mandibular nerve. That means in the mesencephalic nucleus, the relay did not take place. The mesencephalic nucleus will receive the proprioception. It goes to the mesencephalic nucleus, and from there only the fibers are sent to the motor nucleus. And that tells me that mesencephalic nucleus is the site for pseudo-unipolar neurons also. To have a monosynaptic reflex, we need pseudo-unipolar neuron, and you'll be surprised to know that in the entire central nervous system, there is no other place where we have pseudo-unipolar neuron except for this nucleus. Outside the central nervous system, there are loads of examples. Dorsal root ganglia, geniculate ganglion, trigeminal ganglion, they all have pseudo-unipolar neuron. But when it comes to the central nervous system, this is the only and only site here. So that's a good question to ask, guys. This is the only site for pseudo-unipolar neuron. It is the only site for pseudo-unipolar neuron, but importantly, where? In CNS. It is the only site for pseudo-unipolar neuron in central nervous system. So look, multiple questions to be asked on the mesencephalic nucleus. One, it is a site for proprioception. It is a center for jaw reflex, or you can say mesenteric reflex. And it is also the only site for pseudo-unipolar neuron in central nervous system. Like you say pseudo-unipolar, or even if you say unipolar, that is also correct only, guys. Developmentally, it is unipolar only, and then eventually it converts into the pseudo-unipolar neuron. So that is okay. I mean, some of the books will say unipolar neuron, You can go with that, but yeah, the exact right answer to say it actually is a pseudo-unipolar neuron present in the mesencephalic nucleus. So this is overall about the cranial nerve nuclei and columns. And if I take you back to the table, guys, we have discussed quite a few details in that. Now, understanding the meaning of column, that is one thing which is required. Then we need to know what nucleus is present in, and then the level of the nucleus also becomes important. That where is third nucleus present in the midbrain? I mean, even in the midbrain where it is present, I'll tell you that. We'll discuss that in the cranial nerves. Fourth nucleus level, sixth nucleus level, hypoglossal nucleus level in the brainstem. Just saying that it is present in the midbrain is not enough. Where in the midbrain? Is it superior colliculus? Is it inferior colliculus? So those kind of questions will come to that. The second column is all about pharyngeal arches. The third column is all about parasympathetic supply. It's about the parasympathetic nuclei supplying the smooth muscles and gland. GVA and SVA is all about the taste sensation and the general sensation, but from viscera, visceral nucleus. A very, very important, this huge nuclei, the trigeminal nuclei, which is carrying all kind of general sensation from the body wall, whichever nerve it is. And then vestibulocochlear nuclei, which is the only nuclei in the SSA column, although first nerve and second nerve are also the SSA type of nerve. And mind you, this is one topic in which the more you go forward, the more you'll keep on going forward, you'll understand the previous part better. When I will discuss cranial nerves with you, I'll keep telling you, okay, why third nerve is connected to this column, why fourth nerve is connected to this column. So we'll come to that. We'll understand that part here. So this is about the cranial nerve nuclei and the column. I hope you understood this part. Now, okay, let me open the group for a minute because I've kept my phone on the flight mode so that I cannot be disturbed by anything in between. Okay. Okay, all I can see, some sound lagging problem. Yeah, first of all, guys, just don't worry about that. All these things will be saved in this. Well, I'll break down the syllabus till 7th. That will be posted in the group, but that we can do it after the class only, right? We can do that after the class. We're still on the session right now, so I think I should not be doing it right away. What I'll do that after the class, I'll break down the entire syllabus into part, that what portion we are covering on what day and what are the timings for the class, and you will come to know about that. Okay, so I hope that it is all good till now. I think bulbar is for the palate, pharynx and larynx here. The palate muscle, pharynx muscle and larynx muscle, they will come into bulbar. The palate, pharynx and larynx muscle. Why not ipsilateral, Anuj? I mean, if the nucleus of one side is injured, the same side muscle will get involved, obviously. So when you're saying it's ipsilateral, it has to be the ipsilateral involvement here. The same side muscle will get involved. If there is a nucleus of, if I say right side facial nucleus injured, so right side facial paralysis will be there, na? So if there is a right side nucleus ambiguous injury, so right side muscles will get involved. So it's a ipsilateral bulbar paralysis. So I think I should close the group again, and we'll continue. Whatever doubts is, let me just take it after a while. I'll give you a break after, let's say after half an hour or so, then we'll see that. So now, after knowing the cranial nerve nuclei and column, guys, let's talk about the cranial nerves, because it's time, we know that where the nerve is going to start, and now we'll say that, okay, this nerve is starting from this particular point, and we'll take the nerve into its further course, because now we got the exact beginning, the exact point where the nerve is going to start from. So let's start with the three nerves here, that is third nerve, fourth nerve, and the sixth nerve. In this part, we'll discuss the third nerve, fourth nerve, and sixth nerve, and I am going to start my discussion with the third nerve in this case first. Oculomotor nerve. What is the level of oculomotor nucleus? What is the level of the third nerve nucleus? We know third nucleus is present in the midbrain. Fine. But what is the level of the third nerve nucleus? For that, if I take you back to the table of the cranial nerve nucleus column, third nucleus, fourth nucleus, and sixth nucleus, their location, their level is important first. So before I start discussing the third nerve, I should tell you the third nerve, fourth nerve, and sixth nerve nucleus, where their nucleus are situated. To remind you, third nerve nucleus is present in the midbrain, fourth nerve nucleus is also in the midbrain, but sixth nerve nucleus is in the pons. But is it enough? No, sir, it is still not enough here. Third nucleus is in the midbrain, but at the upper part of midbrain, and that is called as a superior colliculus. That is a superior colliculus. So third nucleus is present in the midbrain at the level of superior colliculus. That is, fourth nucleus is also present in the midbrain, but this time it's present at the level of inferior colliculus. Now, what is superior colliculus and inferior colliculus? We will discuss that. We will discuss that superior and the inferior colliculus eventually in the neuroanatomy. We'll talk about that. One section is taken at the level of superior colliculus, one at the level of inferior colliculus, and sixth nucleus is present in the pons, and that is present in the pons at the level of facial colliculus. At the level of facial colliculus. Now guys, facial nerve is the one, facial nerve surrounds the sixth nucleus and comes out. Facial nerve is having a property of surrounding the sixth nucleus and coming out. That is called as a facial colliculus here, right? So it's an internal genu of the facial nerve, which is called as facial colliculus. So it's an important question to know the third nucleus at the level of superior colliculus, fourth nucleus at the level of inferior colliculus, and sixth nucleus is situated at the level of facial colliculus. It is present at the level of facial colliculus. Look, it's also imperative to understand that how they formulate the questions in this. They will give you a picture of an extraocular muscle, and you have to identify the muscle. You should know that the muscle is supplied by what nerve. Then you need to know the nerve is coming from which part of brainstem, and then in which part of the brainstem, is it superior colliculus, inferior colliculus, where they're starting. For example, let's say if they give you a muscle, medial rectus muscle. I'm just giving you an example here, and this is what they've done in past also. Let's say this is the eyeball we are looking at here. Here is the optic nerve. And let's say they've just given a view like this. This muscle here is a superior oblique. We know that's how the superior oblique muscle will be present. That's a superior oblique muscle. Let's say the view is from the lateral side here. This muscle here is a lateral rectus. Then we have muscle like here, that is an inferior rectus. So different muscles are shown. For example, if they put an arrow on this muscle and they will ask you, okay, this muscle is having its nucleus starting from where? So first I need to identify, okay, what muscle is that? I can identify this muscle is what? Superior oblique. The muscle is superior oblique. Superior oblique muscle we all know is supplied by what nerve? Fourth nerve. And we just said fourth nerve is coming from the level of what? Inferior colliculus, and that's the answer here. Fourth nerve is coming from the level of midbrain at the level of inferior colliculus. If let's say they mark this muscle here, what muscle is that? That is inferior rectus, or maybe superior rectus, or maybe inferior oblique. So inferior rectus supplied by what nerve, guys? Inferior rectus supplied by the third nerve. We all know inferior rectus is supplied by third nerve. Third nerve is coming from where? Midbrain, but this time the level is what? Superior colliculus. Even superior rectus is coming from superior. I mean, all the muscles supplied by third nerve, the level is superior colliculus. And let's say if the arrow is marked on this muscle, that is lateral rectus muscle. Lateral rectus is supplied by the abducens nerve, the sixth nerve, and abducens nerve comes from the pons at the level of facial colliculus. They have already asked this question on this, that third nerve is present at the level of third nucleus is present at what level? Superior colliculus. Now, there are very good possibility they can ask you the superior oblique muscle also, they can ask you lateral rectus muscle also, or they can ask you any other muscle supplied by third nerve. So the first job is to identify the muscle correctly, then knowing that what nerve is supplying that muscle, and then finally also knowing about that where the nucleus is present. Right? So that's a kind of question they can ask you in third nerve, fourth nerve, and sixth nerve. Okay, let's take these nerves one by one and understand that what kind of function they are performing, what column they will come into. So here we go, guys. Let me start with the third nerve first, the oculomotor nerve. Now, this is the first type of nerve we are discussing here. So I should tell you the way I will approach the nerve is I'll start usually from the left side of the page, and I recommend you to go in this direction. We'll discuss the nerve in this direction here. So I'll put a part of the brainstem there, the cavernous sinus, the superior orbital fissure, the orbit. So different component will put it this way. As we know, third nerve is starting from the midbrain at the level of superior colliculus. So guys, let us say this is a transverse section of the midbrain sideways. This is a midbrain section, and this midbrain section is taken at the level of superior colliculus. This midbrain section is taken level of superior colliculus. Just remember one thing, guys. Generally, when you take the midbrain section in the neuroanatomy, when I'll take the section, obviously we'll draw the section like this, in this manner here, the peduncle and the colliculus here. But because I have to discuss a nerve like in a side way, that's why I put it in this manner. So this is a section of the midbrain, right? This is a section of the midbrain you're looking at. The section of the midbrain, and you can already see the section is taken at the level of superior colliculus. Now let's mark few important elevations there. Like as you can see, this one here, in the ventral aspect of the midbrain, we have these elevations, this white matter bundle elevation here, which are called as a cerebral peduncles. These are called as cerebral peduncles. The cerebral peduncle. It's a part of midbrain, but we call it cerebral peduncle. Why do we call it cerebral peduncle? Because all the descending tracts of cerebrum are present in this area here. So we call it cerebral peduncle. It is the descending tracts are present in this part, so we call it cerebral peduncle. Then there is cavernous sinus, which is present in the middle cranial fossa. Let me put this cavernous sinus here. This is the, let's say, middle cranial fossa. The nerve is starting from here, from the brainstem, and then going into the middle cranial fossa. What we have in the middle cranial fossa is the cavernous sinus. We will be discussing the details of cavernous sinus eventually, but let me just write the sinus for now. This is the cavernous sinus. And if I go further, let's say this is a superior orbital fissure. We know that's how the nerve is going to enter the orbit. That is through the superior orbital fissure. Sorry, that's the superior orbital fissure. I'm writing SOF there, superior orbital fissure. And finally, these are the muscles which are to be supplied. We know which muscles are supplied by third nerve. Well, except SO4 and LR6. Except SO4 and LR6, all other muscles will be supplied by this. So this will include the muscle that is superior rectus, above the superior rectus we have this muscle that is LPS, that is levator palpebrae superioris, that is medial rectus. I'm just marking those muscles which are supplied by third nerve. We're not going to put the superior oblique and lateral rectus in this. So this is inferior rectus. And let's say this is inferior oblique. Coming from the floor of the orbit, like this is the inferior oblique muscle. Right? So no lateral rectus or no superior oblique in this. Now that's the platform we need to discuss the third nerve. We got a midbrain there. We got a cavernous sinus. We have superior orbital fissure. And you're looking at the extraocular muscle which are supplied by the third nerve. Look guys, if this is a midline of the midbrain, so you will see oculomotor nucleus of the right side, and that is an oculomotor nucleus of the left side, and they are kind of ventrally fusing with each other. Like the oculomotor nuclear complex is something like this, that the right side nucleus and the left side nuclear complex, they are fusing in the midline. Yes, we have a right side nucleus separate, left side nucleus separate, but they're fused also in the central part. So that is a third nucleus over there. That is a third nucleus. And apart from third nucleus, which other nucleus is required for third nerve? We know that is Edinger-Westphal. Let's say if I put this as EW, this red nucleus which I'm drawing here, that is, let me write it EW, Edinger-Westphal. So that's a two nucleus which are the nucleus for third nerve. So one obviously is the main third nucleus, oculomotor nucleus, and Edinger-Westphal, which is a parasympathetic nucleus. Let's take care of them one by one. Third nerve. Starting from this third nucleus, what you'll see, I'm just looking at the nerve of one side. Guys, please understand this first. We are just talking about one side only. I'm drawing the entire midbrain here, but I'm looking at we will be discussing nerve coming from one side, going to one side of the cavernous sinus, one side of superior orbital fissure, and one side of the orbit. Okay. So the nerve coming from this third nucleus, first of all, it leaves the midbrain by passing through this fossa, which is called as an interpeduncular fossa. You can see this is a peduncle, this is a peduncle, and there's a fossa in between. So third nerve is a content of interpeduncular fossa. The first point to be noted here, the third nerve, it is a content of interpeduncular. Third nerve is a content of interpeduncular fossa. So it leaves the midbrain by passing between the two peduncle. We will be discussing more details about this interpeduncular fossa and everything in the neuroanatomy, but for now you know that it is a content of interpeduncular fossa. Then you will see the nerve, the third nerve, it actually runs between the two arteries. Again, I cannot discuss these arteries for now. I'm just putting the artery over there, but I definitely will justify these arteries in the neuroanatomy. There are two arteries. One is the posterior cerebral artery, the PCA, and one is superior cerebellar artery. And you will see the same exact story with the fourth nerve also. When the fourth nerve will come out of the brainstem, it is also passing between the posterior cerebral and superior cerebellar artery. So another point to be noted here, the artery. It runs between what two artery? The PCA. PCA, you know, that is posterior cerebral artery. And SCA, it stands for superior cerebellar artery. Right? The third nerve, when it leaves the midbrain from the interpeduncular fossa, it runs between these two arteries also. And that makes this artery vulnerable in the aneurysm of the posterior communicating artery. We'll discuss that because this artery is it's between the two arteries. So let's say the nerve can get compressed between the two arteries, or the aneurysm of the artery can compress any of these two nerves here. So between posterior cerebral artery and superior cerebellar artery, and both these arteries are the branches of basilar artery. That we will discuss. Just write the names of the artery for now. In the further course, the third nerve, it runs through the lateral wall of cavernous sinus. Now, remember that it is in the lateral wall. This nerve is present in the lateral wall of cavernous sinus. The nerve is in the lateral wall. It's not going through the cavernous sinus. It is present in the lateral wall of cavernous sinus. And then, finally, before the third nerve enters the superior orbital fissure, it divides into one upper division. Upper division will go and supply the upper two muscle, that is LPS and SR. And it also gives off a lower division which will supply the remaining muscle, the medial rectus. It supplies inferior rectus. It does supply inferior oblique also. So the two divisions you can see, guys, there is an upper division. I'm writing UD and LD, upper division and lower division, and that is supplying these muscles. Upper division supplies the upper two muscle, that is LPS and SR, and lower division will take care of the remaining muscle, the medial rectus, the inferior rectus, and inferior oblique. So third nerve coming from the third nucleus comes out of the interpeduncular fossa, runs between the PCA and superior cerebellar artery, eventually runs in the lateral wall of cavernous sinus, divides into upper and lower division before entering into the fissure. So when we talk about the contents of superior orbital fissure, we have an upper and lower division of third nerve. Upper division for the upper two muscle and lower division take care of the remaining three muscles there. Right? That's the third nerve. That's how it is going in doing the motor function, supplying the muscles. What about Edinger-Westphal? The question is now Edinger-Westphal, guys. Edinger-Westphal fibers, they run in the third nerve only. I'm just using a different color to show that. Edinger-Westphal fibers, they're running in the third nerve. Then they will be running with the lower division. And what you'll see, eventually they will run with the nerve supplying the inferior oblique, and this is where they separate and they relay in the ganglion, the only ganglion in the orbit, and that is what? Ciliary ganglion, guys. They relay in this ganglion, that is a ciliary ganglion. That's the parasympathetic ganglion present in the orbit. That is ciliary ganglion. That's an important point. We will be discussing all these parasympathetic ganglion in detail. Just write this name for now. That is ciliary ganglion. It is present in the orbit. And this, you can see Edinger-Westphal fibers are the one which are using the third nerve, the lower division, the nerve to inferior oblique, and they separate and release into the ciliary ganglion. And guys, from the ciliary ganglion, the multiple short ciliary nerves will come out. The multiple short ciliary nerves will come out. I'm just writing in short only SSN, short ciliary, SCN, that is short ciliary nerves. Multiple short ciliary nerves will come out, and it's their job to supply the sphincter pupillae and ciliaris. The smooth muscle. Well, we know that Edinger-Westphal job is to supply the smooth muscle only. So that supplies sphincter pupillae and ciliaris muscle. That supplies sphincter pupillae and ciliaris. This is how the smooth muscles are supplied, guys. So fibers of the Edinger-Westphal, you can see they're running with the third nerve. After running with the third nerve, they will go with the lower division. Then they will go to the ganglion, that is ciliary ganglion. And once they're done relaying into the ciliary ganglion, the post-ganglionic nerve fibers, the multiple nerves, short ciliary nerves will come out from there. And then these short ciliary nerves will go and supply the sphincter pupillae and ciliaris muscle. Remember, dilator pupillae is supplied by sympathetic nerve. So not dilator pupillae, of course. It's sphincter pupillae and ciliaris. Dilator pupillae is by sympathetic nerves. Okay, so this is how exactly the Edinger-Westphal is doing the parasympathetic function, and oculomotor nucleus is doing the motor function of supplying the muscles, right? You can see that's a third nerve in front of you. You're looking at the course, the relations, and the supply also. Now, there is something very special about the third nucleus, if I would say, the third nuclear complex here. And let me tell you in more detail here. Third nucleus of the right side and third nucleus of left side, we said they're kind of fusing in the midline. This nuclear complex is fusing in the midline. Something like this. Look, if this is an oculomotor nucleus of the left side and here is the oculomotor nucleus of the right side, and we said they are fusing in the midline. If let's say this is the midline here. Now, no problem. Third nucleus of the left side will still go and supply the muscles of the left side only. It is supplying the extraocular muscle. This third nucleus, let's say of this side here, will go and supply the muscles of this side. Again, no problem with that. Except one, superior rectus. Whatever muscles are supplied by third nerve, superior rectus is very special. What makes the superior rectus special, guys? Let me just write the superior rectus muscle of both the side here. Superior rectus of left side, superior rectus of right side. Superior rectus is supplied by the nerve. Now, I'm drawing it in a reverse manner, guys. Superior rectus is supplied by the nerve, which is, the nerve is of the same side only, but its nucleus is actually present on the contralateral side, like this. If I do it this way also, superior rectus is supplied by the nerve is fine, but what do you see? If I trace the nerve back, the nucleus is present on the contralateral side. So it is not wrong to say that superior rectus is supplied by the third nerve of the same side only. Nerve is of same side. If I trace the nerve from here to here, it is the same side nerve, but the nucleus is on the contralateral side. So superior rectus innervation comes from the contralateral oculomotor nucleus. Superior rectus is a muscle which is supplied by, that's a question here. Superior rectus is supplied by, contralateral oculomotor nucleus. Not the nerve, guys, I'm saying nucleus. Contralateral oculomotor nucleus. It is supplied by the contralateral oculomotor nucleus. So if the question says, what about the nerve? Yes, ipsilateral nerve. Third nerve of the right side will supply the right side muscle, including superior rectus. But when it comes to the nucleus, superior rectus is supplied by the contralateral oculomotor nucleus. If I may highlight this for you, the superior rectus of the left side is supplied by the right side nucleus and vice versa. The innervation of the superior rectus comes from the contralateral oculomotor nucleus. That's a unique example in which the nerve is decussating inside the nucleus only. Generally, the nerve decussates before the nucleus, after the nucleus. Here, the nerve is decussating inside the nucleus only. The intranuclear decussation here. You can see the fibers of superior rectus decussate inside the nucleus itself. Right, so this is something about the third nerve, guys. The content of interpeduncular fossa, we saw it is passing between the posterior cerebral and superior cerebellar artery. The relation to cavernous sinus, we said it is in the lateral wall of cavernous sinus. We saw how it is entering the superior orbital fissure. And we also saw something very special about superior rectus. That's a question asked in the AIMS exam. That superior rectus muscle is supplied by the contralateral oculomotor nucleus, opposite side oculomotor nucleus. Let's have a quick discussion about that. What will happen if there is a third nerve palsy? In third nerve palsy, if there is an injury to third nerve, for whatever reason, guys, if there is an injury to third nerve because of any syndrome or direct injury to third nerve because of any aneurysm. So in case of third nerve palsy, if I just take the important muscle supplied by third nerve and based on that we understand the feature. For example, it supplies the LPS muscle, levator palpebrae superioris. Now we know that levator palpebrae superioris is to elevate the eyelid. So injury to the LPS will lead to what? To the ptosis. That will be ipsilateral ptosis. There is a drooping of the eyelid, that is a ipsilateral ptosis will be there. It supplies medial rectus muscle. I'm purposefully taking some individual muscle. It supplies medial rectus muscle also. Third nerve supplies medial rectus. If your medial rectus is not working because of third nerve palsy, the lateral rectus will take over. Lateral rectus is supplied by sixth nerve. So the sixth nerve will supply the lateral rectus and lateral rectus will take the eyeball away from the midline and that causes a squint. What kind of squint? It's a divergent squint. Ipsilateral divergent squint. Then we got superior rectus muscle. Guys, superior rectus is supplied along with, let me say, inferior oblique also. Superior rectus and inferior oblique, let's consider them together. Superior rectus and inferior oblique both are supplied by third nerve. Now, do you see any similarity between the function of superior rectus and inferior oblique? I'm sure you know that both superior rectus and inferior oblique, they are responsible to elevate the eye. When you look up like this here, that is done by the superior rectus also, and it is also done by the inferior oblique also. So both will elevate the eyeball. If both superior rectus and inferior oblique are not working, that will cause ipsilateral downward rotated eyeball or depressed eyeball. Ipsilateral downward rotated eyeball, or you can say it's a depressed eyeball here. Ipsilateral downward rotated eyeball or depressed eyeball. Look, if I just try to put the three features together, just to show you in the diagram here, guys, let us say this is a normal eye. This here is a normal eye you're looking at. And this is the one with the third nerve palsy. Now, one with the third nerve palsy, first of all, it will show ptosis. So there is a ptosis, number one. You can see there's a drooping of the eyelid. Second thing you will see that eyeball is out. It is a divergent squint and it is rotated downward also. Down and out eyeball. The eyeball is down as well as out. Look at that. Can you see it is down as well as out? So it's a divergent squint. The eyeball is abducted. The eyeball is rotated downward also. So it is down and out eyeball along with the ptosis. That's a feature of third nerve palsy. That's how the eye will look like. Your eyeball will be out as well as down, and there's a ptosis also in that. Apart from that, sphincter pupillae and even ciliaris muscles are affected. Sphincter pupillae and ciliaris muscles are also affected in third nerve palsy because Edinger-Westphal is using the third nerve to supply them. Now guys, if sphincter pupillae is not working, and cilia is not working, what will be the outcome? Sphincter pupillae is not working, that will lead to the ipsilateral dilated pupil, the mydriasis, ipsilateral dilated pupil, and also there is a loss of pupillary light reflex. The pupillary light reflex will be gone, right? Pupillary light reflex will not be there because the sphincter pupillae is not working. How can we have light reflex here? And similarly, the ciliaris muscle. Ciliaris muscle is also affected, and ciliaris muscle involvement will cause what? It will lead to the ipsilateral loss of accommodation. Ipsilateral loss of accommodation, or you can say ipsilateral loss of accommodation reflex. Ipsilateral loss of accommodation. right? So ipsilateral ptosis, divergent squint, downward rotated eyeball, dilated pupil, loss of light and accommodation, like the typical feature of third nerve palsy. I hope you all know all these features here. The typical features of third nerve palsy will be there if the third nerve is injured here. So this was about the normal anatomy of the third nerve and about what the third nerve palsy can lead to. Okay, chalo. Let's move on to the next nerve, and the next nerve here is a fourth nerve, guys. Trochlear nerve. We said we'll be discussing these three nerves together: third nerve, fourth nerve, and sixth nerve. Now, trochlear nerve. If you know the plot for third nerve, you know the plot for the fourth nerve also, because fourth nerve will also start from where? Midbrain only. The only difference is the level will be the inferior colliculus, and rest everything remains the same. I mean, the plot remains the same: cavernous sinus, superior orbital fissure, and then again the muscle to be supplied, superior oblique muscle to be supplied. So let's talk about the fourth nerve or the trochlear nerve. The origin of the fourth nerve, we know it is at the level of inferior colliculus. So once again, guys, this is the transverse section of the midbrain, but this time we are taking a transverse section of the midbrain at the level of the inferior colliculus. I'm writing IC over there as inferior colliculus. Rest everything is same. We are still looking at these peduncles. That is a cerebral peduncle there. The cerebral peduncle. This time you will see oculomotor. This, unlike oculomotor nucleus, the fourth nucleus are separate on the right and left side. It's the fourth nucleus of the right and the left side, both separated. And the rest of the plot is also the same, guys. Once again, I need to put a cavernous sinus there. That is cavernous sinus. Same again, superior orbital fissure. And this time only one muscle is to be taken care of, and that is superior oblique muscle. The muscle is superior oblique. So here we have superior orbital fissure. This is once again the cavernous sinus. Okay. So after putting the plot, the section of the midbrain at what level? Inferior colliculus, and rest everything is same only, guys. We're again looking at cavernous sinus, superior orbital fissure, and the superior oblique muscle. Now look, fourth nerve, something unique about the fourth nerve, that the lower motor neuron of this nerve will decussate. Upper motor neuron, lower motor neuron. Generally, upper motor neuron decussate. In this nerve, the lower motor neuron will decussate, and they will decussate inside the midbrain only. What do you say? The decussation inside the brainstem. So fourth nerve decussates inside the brainstem like this, and then you will see the nerve will come out from the dorsal aspect of the brainstem. Comes out of the dorsal aspect of brainstem. In fact, this is the only nerve which is emerging from the dorsal aspect of brainstem. Let me follow the nerve of one side. It will wind around like this, and then exactly same thing. Lateral wall of cavernous sinus, superior orbital fissure, and ultimately goes and supplies the superior oblique muscle. It in fact even passes between the same two arteries also. It runs between the same two arteries, that is the posterior cerebral artery, and you also, that's a superior cerebellar artery. We already know that that's posterior cerebral and superior cerebellar artery. This also is running in the lateral wall of cavernous sinus, just like third nerve, content of superior orbital fissure, and then supply the superior oblique muscle. So we're just looking at the nerve of one side only. Now it is to be noted, some important point to be note here. That is one, that the lower motor neuron in this nerve, the lower motor neuron, they decussate. The lower motor neuron, they decussate within midbrain. The lower motor neuron, they decussate within midbrain. Number two, it is the only cranial nerve, guys. It is the only cranial nerve which emerges from the dorsal aspect of brainstem. It is the only cranial nerve which emerges dorsal aspect of brainstem. There is no other cranial nerve which is coming from the dorsal aspect. It's the only cranial nerve which emerges from the dorsal aspect of brainstem. It's the only cranial nerve emerging from dorsal aspect of brainstem. And imagine a nerve is coming from dorsal aspect of brainstem. So imagine this nerve has to travel a very long course. First, it has to go back, decussates, goes back, then emerges from dorsal aspect. It winds around the entire midbrain, and then it goes toward the cavernous sinus. So it is traveling for a very long distance inside the cranial cavity, and that's why we say that the fourth nerve is having the longest intracranial course. This nerve is having the longest intracranial course. That's a question also. The nerve with the longest intracranial course, that is the fourth nerve here. We have the different nerves, longest intradural, longest intraosseous, longest extracranial. This nerve is having a longest intracranial. Inside the cranial cavity, the longest course belongs to fourth nerve. Longest intracranial course. Right? So lower motor neuron, as you can see, they are decussating within the midbrain. The nerve is emerging from the dorsal aspect of the brainstem. And then rest is same. It's having the longest intracranial course, but from this point onwards, it is just like third nerve only, running between the same two artery, lateral wall of cavernous sinus, superior orbital fissure, and supplying superior oblique. In the fourth nerve, guys, in the fourth nerve, what we will see, in case of fourth nerve palsy, the superior oblique muscle will get affected. And if superior oblique muscle will get affected here, then you will see that there will be diplopia. There will be a double vision. If superior oblique muscle will be gone, there will be diplopia. Double vision will be there. The patient with the superior oblique nerve palsy, what they do, they generally tilt their head to the other side to compensate for this superior oblique palsy here. Let's say if I have a superior oblique palsy of the right side, what I will do, I will tilt my head toward the left side like this. Like if I have a superior oblique palsy of the right side, I will tilt the head toward the left side to correct the image. So they generally tilt their head to the other side to correct the image. That is the indication of the fourth nerve palsy. So it is supplying one muscle only, that is superior oblique. Which brings us to our next nerve, and the next nerve is what? That is the sixth nerve, guys. We know the third nerve, we know the fourth nerve, and now the sixth nerve, which is a little different here. Why it is different? Because sixth nerve will be starting from the pons. The origin is different. That will make all the difference. So talking about the sixth nerve, that is abducens nerve. Abducens nerve. The origin of the abducens nerve is from the pons at the level of the facial colliculus. We already have discussed that it is coming from pons at the level of facial colliculus. Now guys, let's imagine this here is the pons. That is first let's go with the midbrain here. That is a midbrain part. And after the midbrain, let us say this is a pons. And let's say after pons, there is medulla oblongata. If I just like roughly draw the three parts of brainstem here, this is the midbrain. If this is the pons, and let's say this is the medulla oblongata. Very, very rough representation there. Midbrain, pons, and medulla oblongata. Cavernous sinus is present at the level of midbrain only. Because this is what all going to create all the difference here. Cavernous sinus is at the level of the midbrain. But now the nerve we are going to talk about is coming from the pons. So level is little below. So make sure you draw the cavernous sinus the same level only where we have a midbrain here. That is the cavernous sinus. Superior orbital fissure, that doesn't change. And what also doesn't change, that muscle. That what muscle is to be supplied? That is the lateral rectus. SO4 and LR6. LR6, lateral rectus muscle, is to be supplied by the sixth nerve. So that is superior orbital fissure. And here we have once again the cavernous sinus. That doesn't change. So the rest of the plot is same. The only thing is this time the nerve will come out from the pons here. And look guys, sixth nucleus is present in the pons. Sixth nucleus is present in the pons, but the sixth nerve is not exactly emerging from the pons. Sixth nerve is emerging from pontomedullary junction. Again, something we'll discuss in detail in neuroanatomy. The sixth nerve will leave the brainstem from pontomedullary junction, and then you will see this nerve is ascending upward to reach the cavernous sinus. And reaching the cavernous sinus. And before entering the cavernous sinus, the nerve will be related to a sharp apex of the petrous temporal bone. Something I'll show you in the osteology part. Apex of petrous temporal bone, which is quite sharp. Temporal bone is having a squamous part, petrous part. It's the apex of the petrous temporal bone which is sharp, and the nerve is very close to that. There is an apex of the petrous temporal bone. apex of the petrous temporal bone. As you can see, nerve is in relation to the apex of petrous temporal bone, where it is also passing through a ligamentous canal. It's a petroclinoid ligament, guys. The name of the ligament is not important. It's a ligament called as a petroclinoid ligament, or you can, and this ligament is forming a canal, and this canal is called as a Dorello's canal. So your sixth nerve is passing through this canal, which is called as a Dorello's canal. The name of the canal is important. So there is a ligamentous canal which is close to the apex of the petrous temporal bone, that is the Dorello's canal, and this Dorello's canal is giving passage to the sixth nerve. So when the sixth nerve, after going through the apex of petrous temporal bone, a sharp apex of petrous temporal bone, it goes into the cavernous sinus. The nerve also is seen. What is the relation, guys? This time it is changed. Third nerve and fourth nerve are in the lateral wall of cavernous sinus, but this nerve is present inside cavernous sinus. This nerve is not in the lateral wall. This nerve is like going through the cavernous sinus. It is inside the cavernous sinus, and then ultimately it goes through the superior orbital fissure and ultimately reaches the lateral rectus. Right? So it's a very important change of relation that you will see. This time the nerve is present inside the cavernous sinus. Third and fourth nerve are in the lateral wall, but this nerve is inside. What makes sixth nerve special, guys? There are a few important points about the sixth nerve that you need to write down. Number one, sixth nerve is the nerve with the longest intradural course. It's the nerve with the longest intradural course. This nerve runs inside the durometer for a very long distance. It runs obliquely inside the durometer first. It enters the cavernous sinus. Cavernous sinus itself is a durometer only. So the nerve is having a very long course inside the cranial cavity, inside the durometer, longest intradural. Fourth nerve was having the longest intracranial. This nerve is having the longest intradural course inside the durometer. It is also to be noted that we already said that nerve is inside the cavernous sinus. That is very much visible in the picture. We don't have to write that. See, the nerve is very close to the apex of petrous temporal bone, and that makes the nerve vulnerable to injury also there. When there is increased intracranial pressure, what happens is in increased intracranial pressure, the brainstem will try to descend downward. There is a pressure on the entire brainstem, and the brainstem will try to descend downward. Now imagine if this brainstem try to descend downward, the nerve is also pulled down. And if the nerve is pulled down, the nerve can get injured on the apex of petrous temporal bone. That's why the sixth nerve is most commonly injured in increased intracranial pressure. It is most commonly injured in increased intracranial pressure, guys. The sixth nerve is most commonly injured in increased intracranial pressure. And it's a bilateral injury, because obviously when the intracranial pressure increases, when we talk about intracranial pressure increase, we presume it's a bilateral increase. On both the sides it is increasing here, which is pushing the brainstem down. And when it is pushing the brainstem down, what will happen? The nerve of both the side will get injured on the apex of petrous temporal bone. So it's a bilateral injury that we talk about here. Now the question is, what will happen if there is an ipsilateral increase of intracranial pressure? Sixth nerve injury is there when the bilateral increase of pressure is there. Overall increase, intracranial pressure is increased and the brainstem is descending downward. If the pressure is increasing on one side, let's say there is an extradural hemorrhage, there is a tumor developing on one side, and that will push the brainstem sideways. Instead of downward, the brainstem will go sideways. And when the brainstem goes sideways, guys, the most commonly injured nerve is the nerve which is coming from the interpeduncular fossa, that is a third nerve. I want you people to please go back to the third nerve and write there that third nerve is most commonly injured in the ipsilateral increase of intracranial pressure. We will understand this more about this in the neuroanatomy here, but at least right for now, the third nerve is most commonly injured in the ipsilateral increase of intracranial pressure. The nerve is coming out from the interpeduncular fossa, so on the margin of peduncle it will get injured. Third nerve is most commonly injured in increased intracranial pressure. Increased intracranial pressure, ipsilateral increase. If it is an overall increase of intracranial pressure, then it is a sixth nerve. Then it is a sixth nerve. Third nerve is most commonly injured in ipsilateral increase of intracranial pressure. Now guys, in case of sixth nerve palsy, obviously lateral rectus muscle will be involved. And we know that lateral rectus muscle is for the abduction. If your lateral rectus muscle, your abductor is gone, so eyeball will get adducted. And that will lead to ipsilateral convergent squint. the patient will have a ipsilateral convergent squint, guys. There will be ipsilateral convergent squint, right? How this ipsilateral convergent squint will look like, if I have to show you diagrammatically, like this is a normal eyeball. Once again, that's a normal eyeball. And let us say this is the case of the convergent squint. So you will see it's a convergence. It's converging toward the medial side. Adduction, the eyeball is adducted here. That is convergent squint will be there. So guys, this is about the third nerve, fourth nerve, and the sixth nerve. The three cranial nerves which are supplying the extraocular muscle. And third nerve is not only supplying the extraocular muscle, with the help of the Edinger-Westphal, it is also taking care of the sphincter pupillae and ciliaris muscle, the two smooth muscles as well. So eyeball muscle, whether it's a smooth muscle or the skeletal muscle, that's how they are taken care of. And what are the effect of the injury to these nerves. So knowing about the nerve, where it is starting from, the level of the nuclei, which part of the brainstem, how it comes out. Is it coming out from an interpeduncular fossa, or it is coming out from the pontomedullary junction? Like this nerve is coming from pontomedullary junction. You can note that also. The sixth nerve is coming from pontomedullary junction. Then the relation to cavernous sinus, third and fourth nerve are in the lateral wall. Sixth nerve is inside the cavernous sinus. Sixth nerve is vulnerable to injury because of its relation to the apex of petrous temporal bone. And then what muscles they are going to supply. So this is about the third, fourth, and the sixth nerve. About the nuclei of all these nerves, so what we'll do, guys, once we're done with all the cranial nerves, at the end of the cranial nerve only, I want to do this at the end only. At the end of the cranial nerve, we'll put a table for the cranial nerves here. That, like, third nerve will come under which two column? Like GSC is there, GV is there. Sixth nerve will come under which column here? Because by that time you'll be knowing about the functions already. It will be easy for you to decipher all the nerves that which column they should come into here. So we will keep it for the last when we'll finish off all the cranial nerves, right? So this is about the 3, 4, and the 6th nerve. Chalo guys, with that, I'll give you a break also at this point. Let me open my phone. Don't worry, I'll give you the good breaks in between. So in the meantime, I'll answer your the queries. We'll take a break, guys. We'll take a break of exactly half an hour, right? And then we'll again have a little longer session the same way. We'll have just one more session after that, a continuous session, and then we'll finish off as many cranial nerve as we can. We'll try to do that, right? In the break time, I'll try to take care of your doubts also. If not right now in the break time, then obviously after the class I'll look into all the doubts. We already have one common group to look into it, so no worries. Your doubts will not go unanswered. Okay.